Countdown and yes, now live. Yes.
Shall we start, madam?
We are live now, ma'am.
Yeah. So good evening, ladies and gentlemen. Welcome to the E-Classic for Clinicians PPH Skill and Drill, organized under the aegis of Bengal Societies of Asansol, Bardhaman, Malda, Shiliguri, and West Medinipur societies. The topic today is PPH, postpartum hemorrhage. Any pregnant woman who will deliver is at risk of PPH. The disease burden makes it a global priority, especially for third world countries. The problem is either too little or too late. That is, patients do not get the right treatment at the appropriate time. The strategy is to stay prepared to handle these emergencies. So let us join today for this webinar of imparting knowledge and learning and also sharing our experience. Let us start with a lamp lighting. Today's organizer is Dr. Sadhna Gupta. It is my privilege and honor to introduce her, though she needs no introduction. She is the co-chair of SAFOG NCD Committee, FOXI representative to SAFOG, Vice President FOXI 2016, ICOG Governing Council member with Best Governing Council Award, corresponding national editor of our FOXI Journal, FOXI past chairperson of FOXI Safe Motherhood Committee, and 3 times Corion Award winner, 4 times Best AICOG Research Paper Award winner, sole author of many textbooks, contributed chapters in many textbooks of ICOG and FOXI, then awardee of chancellors, and Dr. Naval Kishore Gold Medal for Best MBBS and Postgraduate Student, and many more to her credit. So may I request Madam to welcome our chief guest, Dr. Geeta Ganguly Mukherjee Madam, and guest of honor, Dr. Ram Prasad De.
Thank you, Mosme. Can we stop slide share? So a very good evening to all, and it is a real pleasure to have all society, Asansol, Bardhaman, Malda, Siliguri, and West Medinipur, because that is your effort and your coordination that we are meeting today on the very, very important aim that we must have the preventable mortality from the preventable PPH. What we can save criticality and mortality from the postpartum hemorrhage in all settings. Important thing is that we have to save lives in all settings, in all places, irrespective of where the doctor is residing, what is socioeconomic status of the patient, what is the income of the patient. So this is the mission of this series of E-Classic and Clinician Skill and Drill PPH workshop, because our aim that every obstetrician and gynecologist for all age group, be it a young budding resident or be it a young practitioner or any person working in the teaching institution or corporate sector, they must have the uniform knowledge as well as the skills, so they are ready to handle any sort of postpartum hemorrhage with very great confidence and the clarity. So a warm real thanks to Asansol President Dr. Vishwajit Ghosh and Dr. Shankar De, from Bardhaman, Dr. Sushant Kumar Das, Dr. Amit Vapal, from Malda, Dr. Rudrendu Chatterjee and Dr. Ratan Kumar Das, Siliguri, Dr. Pushta Behari and Dr. Udyan Sarkar, and from West Medinipur, Dr. Anup Kumar Malik and Dr. MP Malik. Because gratitude, heartfelt gratitude that you gave the date at such a short notice, and all faculties came forward, so that we look forward to a great sharing and the learning session together in next 2 to us. So Dr. Geeta Ganguly has kindly accepted to be chief guest of the event. Somehow she is the place where the internet is not approachable. So can I have CV of Dr. Geeta Ganguly? And she has sent her best wishes. So Dr. Geeta Ganguly Mukherjee is a very, very well-known figure. She has been a mentor, teachers of teachers. So she has worked as a chief of Center of Excellence and officer in charge in ICMR at RG Kar Medical College, a lot of lectures, oration. She has been ex-president of Bengal Obstetric and Gynec Society and vice president of FOXY and the president of ISOPARP as well. She has been the past chairperson of ISAR Bengal, organizing chairperson of ISAR 2018 and president RN Ganguly Foundation. Her special interest is medical education, infertility and reproductive health and social activities. And she has contributed a lot by editing, authoring many books. So it is really great. We are missing her in person due to internet connectivity. I request Moshmi to read out Madam's message so that we are all blessed with her guidance.
Dr. Geeta Ganguly Mukherjee Madam has sent her message today. That very good evening to you all. PPH is a leading cause of maternal mortality, particularly in developing countries. So prevention and immediate management is very important. Risk factors for PPH are many, particularly malnutrition, anemia, multiparity, history of previous PPH or retained placenta. In the present pregnancy, placenta previa, multiple pregnancy, and mainly no antenatal care. Correction of anemia, proper antenatal care, and institutional delivery are very important for prevention and management. I'm sure this webinar by learned participants will throw lights on the various aspects of PPH and its management, and the clinicians will be very benefited. I'm really honored for your invitation to grace the occasion as chief guest, but due to preoccupied assignment on the same time, my presence during the webinar is not possible. Really, I'm sorry for this. However, I sincerely wish that the event will be very successful and will be very effective for the clinicians. My heartfelt congratulations to you, Dr. Sadhana Gupta, for organizing such an important aspect of our obstetric practice. I wish you success in life.
Thank you. So we are really blessed to have Dr. Geeta Ganguly's good wishes and blessings. Dr. Ram Prasad Dey, again, a very, very eminent teacher. He has accepted to be guest of honor in today's evening, and he has been the vice president and past secretary of Bengal OB-GYN Society, editor-in-chief, Indian Journal of Perinatology and Reproductive Biology, national executive member of ISOPAR, national corresponding editor of Jogi, Foxy, Mrs. Chandravati Devi Jagannath Singh Prize, best paper on oncology, and the best Golden Jubilee Suvilja Award for best paper on menopause. And he has been examiner for undergraduates and postgraduate. More than 45 publications to his credit, peer reviewer of many journals. And we look forward to listen to Dr. Ram Prasad for the program and for overall message as a guest of honor.
Yes, thank you. Thank you. Am I audible? Hello?
Yes.
Thank you, madam, for your kind introductions. At the outset, I must thanks to the organizer, Dr. Sadhana Gupta, and the convener, coordinator, Dr. Mousumi, for inviting me. And it is my privilege and honor to be here with you and all these president, secretary of the different societies of Bengal. So you already have told, and I can see all the president and also the few secretaries of Bengal society. It is my privilege and honor. Regarding this e-seminar, I can only say that this is the very good initiative from Dr. Sadhana Gupta. So I must appreciate her initiative for the e-learning class. Today we have a different session, I think three sessions of e-learning, the PPH prevention management as well as the drill. Yes, all of you know that India has achieved a lot, I cannot say little, regarding the maternal mortality rate, ratio, whatever you call that. We have not yet achieved the target goal of 2020 in around 100. And I am not sure whether we will achieve the sustainable target goal of 70 by 2030. If we consider the West Bengal, as is the West Bengal society, the maternal mortality rate what we have achieved in the last few years, that less than 100, it has suddenly increased to more than 100. And we have identified the PPH is one of the lethal cause, one of the major cause, because not only the PPH, and another factor is the anemia, which Dr. Gita Ganguly has already said. In our West Bengal, even in the India, all parts of the India, the average NFHS data is very, very disappointing as far as the anemia is concerned. Every alternate mother is anemia, and this sort of anemia patient is suffering from the mild degree of PPH. They may not cope with this blood loss, and there is a sudden maternal death. So today's discussion, having all the PPH, the prevention, management, and drill, that is the clinical component, is very much will be discussed in the today's e-learning class. Recently, the FIGO and everybody has adopted the PPH bundle care, where the two components, that is the clinical and as well as the non-clinical component. Today's, I think the entire PPH discussion is the clinical component. The one part only remains, which is the non-clinical part. That has also given importance so many things for the network management, registration, and everything. So I wish this will help us, the clinician, particularly those who are working in the ground zero for the managing the patient, is helpful, the prevention and management of PPH. Thank you once again, all the dignitaries in the dais, as well as the Sadhana Madam, for inviting me for this e-learning. Thank you once again to all of you, and also the viewers also for their attentive listening. Thank you all.
Thank you, Dr. Day. Thank you. You put out the right point that we still have to achieve a double-digit maternal mortality across the India. So this is one of the important vision, and this is important bridging the gaps in our, that is our responsibility. So thank you very much for your kind presence and time. So Maushmi, you can go ahead with the scientific session.
So we shall start with first session, that is keynote address by Sadhana Madam. The topic is prevention, diagnosis, and management of PPH. We have two dynamic chairpersons, Dr. Sushant Kumar Das from Bardhaman Society. He is the president of the society and director of Bardhaman Apollo Nursing Home Private Limited. Welcome, sir. And Dr. Anup Kumar Mollik from West Medinipur. He is working as a consultant at Spandan Hospital, Kharagpur, and he is the president of West Medinipur Obs and Gynae Society. May I request Dr. Das, sir, to please introduce Madam and start the topic. Das, sir.
I have been introduced by you, Dr. Maushmi, so sir can introduce the subject, I think, a little bit about subject.
I'm not sure whether sir has joined. He was trying to join.
No, he is there, but some issue with the mobile. Dr. Anup is there. Dr. Anup, can you?
Madam, am I audible?
Yes,
sir. Yes, sir.
Dr. Sadhana Gupta, MBBS.
Yes.
Yes, Madam, let me introduce yourself. It's a very big job for me. Introducing yourself, introducing your pioneer. So you are a pioneer from the beginning. So actually, I want to see the chart actually.
Chitkal, please show the CV.
Madam, your chart,
Yes.
your CV chart.
Yes.
Co-chair Suffolk NCD committee, Foxy representative to Suffolk 2018 and 21, Vice President Foxy 2016, ICOG Governing Council member 2015 to 21 with Best Governing Council Award 2021, corresponding national editor of peer reviewer journal Obstetrics Gynae India Journal Suffolk, Foxy past chairperson Foxy Safe Motherhood Committee with Dr. Mehrud Hisodia Best thrice country representative in World Health Organization on key women health worker issue, health issue, quality. This is partly seen actually in him. It's finding it difficult to read. 3 times Korean Award winner for best scientific research paper, 4 times sole author of book Cesarean Delivery, Vaginal Delivery, a comprehensive textbook of obstetric gynecology, JP publication. Editor 7, Safe Motherhood Bulletin, ICOG Campus, Foxy Focus, Book Safe Motherhood Indicate Initiative, A Silent Revolution. Awardee 3 times Dr. DC Dr. Prize for Best Foxy Publication and Manual. Awardee of Chancellor and Dr. Naval Kishore Gold Medal for Best MBBS and Postgraduate Student. Key organizer of national and international conferences. Saving Mothers 2016-2019, Avigyan Foxy Figo Suffolk 2021, Prevention of Stillbirth 2021, honored at national and international forum of exemplary work done to reduce maternal mortality, community service and women empowerment, namely Padma Bhushan Kamlabai Hospital Award, Dr. R.N. Malhotra Award and Dr. Durusa Award for Distinguished Community Service. Recipient of Dr. N.A. and Sailaja Pandit Award for Women Empowerment 2021. Economic Times Award for Service in COVID Time 2021. Director and Senior Consultant Obstetric Gynecology, Jeevan Jyoti Hospital, Medical Research Center, Gorakhpur. And Madam, I have already tried to describe your achievements, but I think it is too little. You are a Foxy presidential candidate election year 2023. I wish you all the success, and I hope you come out with flying colors. And now I hand over the mic to you for the program to start on.
Thank you, Dr. Anup, for very loving introduction, and with most of all your precious wishes. That means a lot to us. So with this, I start my presentation and just so. I will be dealing with the basic thing about postpartum hemorrhage before we go to the skill of the surgical management, because actually this is the first line management, where if we are alert at the first step in prevention and the first line management, we can save most of the life and the patient does not go into criticality. I have a big gratitude for always being together around the country and Bengal Society. I have been in person, not only in the Bengal Society, but Bardhaman, Kalyani. So I remember always very lovely evening at Bardhaman, at the road travel from Bengal to Shantiniketan from Calcutta, and of course that wisdom and the brilliance of Bengal, what we have, a legacy of teachers, legacy of institution. So I've been greeting from land of Buddha, and this is the core of the postpartum hemorrhage, that we can never obtain peace in the outer world until we make peace with ourselves. So for dealing with PPH, this peace and the core element is very, very important, because it is something very much troubled environment, not only in our labor room or operation theater, but among the attendant also. So nothing to say, everybody is well aware of it, that the PPH, the biggest cause of the maternal mortality, causing around 150,000 maternal deaths, and out of this 30 to 40% are due to hemorrhage, and Africa and Asia is constituting major proportion of these deaths. However, what is the clinician perspective? And today, when the young obstetrician and gynae are swaying away from the obstetrical practice, which we actually owe to our people, because it is going to happen in 2 to 10% of all deliveries, and out of that 1 by 1,000 can be massive and the life-threatening, and we can lose the patient in a rapid span time of 1 to 2 hours, and obstetrical hysterectomy, massive blood transfusion, admission to ICU, which is actually sometime we have to do for the life-threatening hemorrhage. They are all considered as a part of severe acute maternal mortality, and it is a lifetime scar for the patient, for the obstetrician and their team also. So it is about India, when we are having the third largest economy, we actually are losing the patient out of postpartum hemorrhage, about 35 to 56% of maternal death. So what is PPH? Why we want to reiterate again, and why we want to have a great learning, sharing, like solution to the new challenges? Because it tests your gut. It tests what is the functioning of health system, what is your leadership, how you are ready in the peace, in the normal time. It can be unpredictable. We have a lot of cause, and the important thing is that it can be a huge media and the social, medical, legal, and the issue when we lose any woman with the PPH. What is the big issue in India? That as a obstetrician and gynecologist, we are having all age-old problem. We are like having the small cities, West Mednipur, difficult terrain like Siliguri. We have the hills, we have the sea, we have the rivers. So we are bound to have the 3 delays. Sir has already said that we are having, Dr. Day, that anemia. Every second patient is anemic, and the very good referral system. So these are the things where we still have the gaps, but we have all the new challenges which the Western world is facing. Was the development world, so-called. So we have higher number of cesarean section, more placenta accreta spectrum, more and more women coming with the pregnancy who have myoma, who have the medical comorbidities and coagulopathy, and they are having a lot of few medical disorder, and that makes the management of postpartum hemorrhage more and more challenging. So it is very, very important that we all have, it is not only us, our sisters, our junior resident, we must have a clear flow of thought that we have to be ready for postpartum hemorrhage 24/7, because if you deal with the PPH case successfully, it is moral booster, but losing the patient is something very, very lifetime demoralization. If we do suboptimal management, implication can be very, very high. It is not only well-being of mother, neonate, but also obstetrician, or what I say, potential medical, legal, media, and social issue. So our country today have a political will. Now we cannot say that our country don't have political will. We have air ambulance, good road, we have water ambulance, and we have the air ambulance as well. I was just in Jorhat few months back, and I saw this one water ambulance which will say going from Mudgil to Jorhat. So we have political will, but as a OB-GYN, we must ensure that there is no delay at the tertiary will. So prevention is the best thing. What is the prevention of women? Yes, by doing 2 things. First of all, identification of the risk factors. Secondly, like identification of the risk factor, flash it on your antenatal card. So we have to see, we have to ask the patient, did you have PPH in previous pregnancy? If she is placenta previa, if she is having pre-eclampsia, she is having multiple pregnancy, she is taken anticoagulant, that is the thing that we have to search in our history. Sometimes patient is not going to tell you. Also, you have to give the suggestive question, and when you find these risk factor, flash on the antenatal card with the red ink. So this is very important, and you have to counsel these women that yes, your mother can have the PPH, and you have to be ready with the possibility of blood donation, all money, and where you have to have the delivery. So it is the turning knowledge into action is the thing which is needed. Now, the active management of 3rd stage of labor, like I started my journey in Foxy from 1999 and till today. I've been a strong provocator that how the active management of 3rd stage of labor should be formed uniformly in our institution. Helping Mother Survive program in 2013, I was the main coordinator, one of the main coordinator under like Dr. Hema Divakar. And at that time, we came to know that oxytocin was not kept in the fridge, and the oxytocin failed us because it was no cold chain was there. It was nothing. We were right from the production to the shelf life, and that made the path oxytocin initiative. What I was the coordinator that the oxytocin should be kept into the fridge. So why active management of 3rd stage of labor? It reduced 3rd stage risk of PPH, reduce severe PPH, reduce need for blood transfusion, reduce need of anemia, and decrease need for additional uterotonic medication. So the most important arm of active management of 3rd stage of the labor is oxytocin drug, within 1 minute of delivery of the baby. So this is the thing which actually is the most important thing which we should be doing in our clinical practice. We can give 10 unit intravascular or into the fluid. And what is the beauty of oxytocin? That there is no contraindication, no contradiction at all, no contraindication. So you can give safely, sustain uterine contraction, not much effect on maternal vitals. Misoprostol we are using a lot our OB-GYN, but I wish to say that it is always a second choice when the oxytocin is not available, like in community setting. So it is a reasonable managed drug, but it also has to be kept in a good, it is non-humid condition. So this is very important. However, the refrigeration is not required, but important thing is that misoprostol can cause vomiting, diarrhea, pyrexia, and all should be healthcare providers should be knowing it. So all professional bodies strongly say that the active management of third stage of the labor is very, very important. Now we have since 1.5 years carbetocin, and it is a long wait for OB-GYN, long wait for the women who are having now today, everybody what we saying that we are having around 39-40 degree temperature. So oxytocin, the refrigeration issue is very, very important. And now we have the room stable, long acting oxytocin, which is carbetocin and which has got a very, very strong affinity to the oxytocin receptor. So this is one of the drugs which we are waiting for after champion trial, for which India was a great contributor. And now it is available in all settings. I have been using carbetocin now all cesarean and the vaginal delivery since 1.5 years, and it actually reduces markedly the need of any additional uterotonic. And within a minute, you see, you give the drug carbetocin 100 microgram 1 ml. Next minute, you see the placenta delivering. So it is something a treat to eyes, and it is very, very important drug which has been added to our armamentarium. And why this is important? Because our women, if anemic, if hypertensive, any heart disease, it eliminates the need of oxytocin infusion. So you don't have to put the patient on the IV fluid and oxytocin, which cause antidiuretic effect, who are more prone to develop pulmonary edema. So this is very important. However, again, turning knowledge into action is important. So the drugs should be available with a good cold chain, whatever is the refrigeration or temperature or humidity is required. And the third thing is that every healthcare worker, it is not that only we are knowing, our sisters, our junior doctors must be knowing that you have to preload the carbetocin or oxytocin when the head is crowning, and at that time they deliver the drug within 1 minute. So the 4 arms are there for the active management. One is the oxytocin, next is the controlled contraction if the healthcare worker is experienced. So this is very, very important that the controlled contraction, WHO have given word that the stillbirth attendant must be experienced for it. Otherwise, if you do controlled contraction in relaxed uterus or unseparated placenta, then it can lead to further PPH and the inversion also. Late cord clamping, it gives additional benefit to baby. So we are looking for anemia-free India, and this simple intervention as the part of obstetrician and gynecologist will build up the iron stored to the baby, and we will be contributing our contribution to the making anemia-free India. So after this prevention, what we have to be ready, because PPH is unpredictable. So more you sweat in peace, the less you bled in war, and we have to be prepared with our all fire drill. Why do we lose mother, or why do the mother become critical? Because there is delay in correction of hypovolemia and delay in control of bleeding. So here are the 2 things where, as a obstetrician gynecologist, we have to be leading our team that we did the proper resuscitation and medical management. Golden hour, we all know it is the first 2 hours after we recognize PPH. And important thing is that don't shift the labored women who have delivered before 2 hours, so that you don't lose the missed opportunity of unrecognized postpartum hemorrhage or unrecognized atonicity or the hemorrhagic shock. So this is very, very important. And second thing is that we must have a good monitor in our labor room, not only our operation theater, but our labor room also. So every nurse is confident that this is the patient's vital, and she is not like human error and they are thinking and rethinking, should we call obstetrician and senior person or not. So primary PPH, with this a little bit recap: primary PPH, secondary PPH within 24 hours, after 24 hours, all severity. But as a leader of the team, what we do when we are called to the situation, patient is bleeding, first make 360-degree view of the whole situation, because while we are resuscitating, the important thing is that we have a clear cause analysis, that what is the cause of postpartum hemorrhage in this patient. So tone tissue trauma thrombin, we all know, we start reading it from MBBS, but actually cause analysis remains, that is a quick review. So if the patient has the multipetal pregnancy, or she had the chorioamnitis, she was on nifedipine, Maxel, she can have atonic. If difficult delivery, that the trauma can be the cause. If the patient on coagulopathy or pre-existing cause for the DIC like IUFD, preeclampsia, then we can consider that the coagulopathy might be the thing which is causing PPH. So this is important that we know everything, but important thing is that we take a review that what is the cause of the PPH in this particular patient. So difficulty in like bicornuate uterus, when you have a difficulty in the delayed delivery of the placenta, then we think that there can be the retained placental tissue. And this is again important that we have to have this clear instruction to the paramedic that no staff will throw away the placenta, not throw away the biomedical waste before the golden hour has passed, because sometimes you want to recheck whether placenta was complete or not. So atonicity contributing to 70% of PPH, but we have all trauma retained 20%, 10%. Important thing is that many times there are multiple causes of PPH in the same patient. Like if patient have the PROM, that is causing sepsis, that is causing atony. We have given Maxel for neuroprotection or nifedipine for tocolytic, and all contribute to the sepsis, atony, as well as the other cause. So we can have the retained placenta, that we can have the multiple cause. Now about diagnosis. So is it very, very simple? It is everybody can diagnose PPH? No, actually it is not so, because pregnancy, the nature has been kind enough that the women are hypertense, having the hypervolemia due to physiological change in the pregnancy. So they can lose significant amount of blood before they have any reduction of pulse and blood pressure. That's why we miss that golden hour. We miss the patient and we suddenly find that the patient is into the storm. So it is notoriously inaccurate. So the good quantitative estimation, Dr. Nalini Mishra is going to say the Chhattisgarh rape, right on point of the care, you can made it. We have Devdas way, and we must have the clear instruction to the staff. If the patient has soaked 5 normal size pad, or she has soaked 1 big napkin, or she is continuously trickling and she is having a little bit cold, confused, she is not looking, she is nauseating, vomiting, this is the sign that we have to call the senior person and the whole team of anesthetists and everyone on the side of the management of PPH, because we need not only one pair, we need several pairs of hands and brain. So we need anesthetist, senior nurse, obstetrician coolies, ward boys and guys who are very, very smart, theater staff, blood bank person, as well as a one person who can be good communicator. So after this, you are calling your patient and your mind is working very fast and your hand is working very fast. You are seeing what is airway, breathing and circulation, what is the cause and what is the amount of postpartum hemorrhage. So this is green, yellow, red points, but as a clinician, we know pulse high, BP low, tissue perfusion indicator, what is the capillary refill and the urinary output, which gives you very clearly, like quite a clear idea that what amount of hemorrhage we are dealing with, and that quantification, overall quantification with the vitals and the capillary refill is very, very important. Shock index is one of the very, very important simple tool where you divide heart rate to systolic blood pressure. If it is more than 1, then the patient need the full-fledged care for the postpartum hemorrhage. If she is having less than 1, then you have a little bit breathing space. But for this, what we should have, this is important. We have to invest in our labor room with a good cardiac monitor, with the pulse trolley, with a good oxygen support system, good resuscitative system. Only then this technology and this knowledge can result into the preventable mortality as well as the criticality. Golden rule of 30, again, it is the same what shock index is taking, with respiratory rate rising to 30 and urine output is dropping. We have to be ready 24/7, drug, oxygen cylinder, airway, all trays for PPH, for the drugs, for the instrument, chart for PPH management. If somebody new is there, somebody is not having the exposed to the PPH cases or drill, they know what is to be done, and all contact number in mobile number as well as the intercom. So these are the few important things that in intercom, in our mobile, every member, important member should be, number should be saved. So what is basic EMOC? You have to give the resuscitation of the fluid, and when you are putting intracat, that must be always green or the gray. It never should be the pink one, because we have to infuse a good amount of fluid, and catheterization is very important, and sending the blood at the same time, because when the patient is collapsed, like half an hour, if her blood pressure is dropping, it is so difficult to get for the intravenous access, antibiotic giving, recording event, and the communication. So this is very, very important. So with this, we have to have the basic arrest of hemorrhage, keep under close observation. But if it is more than 500, you see it is more than 500, then we have to go for the full resuscitation. So this is very important. Another important, what is the non-technical point in PPH are very, very important. Say one intern or one nurse say that, yes, you come, patient is bleeding, and you say patient is fine, you say always you call me in night, you don't. So next time if she is having any confusion, she will not call you, they will not call you, and you will be losing the time of golden hour. So this is very, very important. So when there is a moderate to severe hemorrhage, airway, breathing, circulation, whatever is the oxygen saturation, give 10 to 15 liter of oxygen and obtain what is green and the gray cannula with the intracat, and always 2 lines. Maybe patient might have stopped bleeding in next 1 hour, but it is always safe to have the 2 intracat line open. Beside this, temperature, flat position, that is flat. If you have not given carbetocin, you can give all oxytocin drug, which will be I will be dealing with, and the catheterize. Aortic compression is one of the life-saving measure, and it is especially in the Paquita-like syndrome when the patient suddenly bleeds such a amount of blood, and we must be knowing that we have to be standing on the right side of the patient on the stool. Our hand should be straight and the thumb should be outside, and it should obstruct the femoral, so you don't feel the femoral when you give the good aortic compression. So this is very, very important. So resuscitate, investigate, monitor, communicate, and record keeping. At the same time, we must have all these vials. It is not only the drugs. In our PPH box, we must have the 3 plain vial, 2 EDTA vial, and 2 citrated vial, along with the blood bank. This is requisition form, because sometimes everything is there and the blood bank form is not making, and everybody is confused at the kiosk, it is not there. So it is important that 24/7 you allocate any senior nurse or somebody that in PPH box, if the drug, if the vials, if the intracat have been used, they are replaced in that. So PPH bundle, what Dr. Day was telling about, it is a set of intervention which can give the good result, and which if we use it with the consistency of the practice. So what is PPH bundle? Uterotonic drug, crystalloid, tranexamic acid, and uterine massage. And then if it is not responding to it, then we go to the next refractory PPH bundle, which will be dealing with the second session. So airway, oxygen, intracat, important thing is the crystalloid. So if you think that it is 500 ml blood loss, then you should give the 1.5 liter of crystalloid. And it is many times like the nurses or somebody say that if we start with the hemaxil. So this is very, very important that the ringer lactate or normal saline is the fluid which we want to have, because colloid infusion remains in intravascular space. they are more prone to have the pulmonary edema. They are not that good volume expander, and they can interact with coagulation tests. So this is very important. Ringer lactate normal saline 3 times more. What is your estimated blood loss? And when there is a 1.5 to 2 liter you have given, and the blood product is not with you and it is needed, then in between space you can give the colloid. Then ask always right question when you are called to the scene, placenta delivered, it was complete or not, did bleeding start immediately after delivery of baby, more chance of trauma, placenta not delivered, mobile for MRP, placenta not complete, then explore genital tract. So giving a good question and a good answer, that makes your system and the time management very, very clear. If there is a suspicion of PS, never go for the MRP because that may cause the life-threatening hemorrhage. So empty catheterization, again, we have to retain all the skill of uterine massage, which is not vigorous rubbing, it is a round circular movement, and always the clearing of blood clot from vagina and uterus is very, very desirable. These are all drugs which we have as a oxytocin for the oxytocin drug for the medical management. Important thing is that we must optimize use of these drugs in a very good way. So we have to know the contraindication like methyl ergonovine, severe anemia, hypertension, heart disease, PGF2 alpha, the glaucoma, heart block, misoprostol. I think there is no much any contraindication. So we have to be a little bit, because we have seen after just methadone patient passed into pulmonary edema, especially in preeclampsia. Second thing is a good storage, good availability. And the third thing is that you must apply the drugs in consecutively. So it is not so if the oxytocin is not effective, then methadone will not work, or the PGF2 alpha not work. So because the uterus have a different receptor, if one drug is not having the uterine contraction, the second will be useful. So you have to have with the sequential administration of all the drug. And the second important thing is give the maximum drug. So you can give 4 injection of methyl ergometrin, oxytocin, you can give up to 100 unit, misoprostol, you can give 600 to 800, and PGF2 alpha, that is 250 microgram, 8 ampule. So don't say that if you have given 1 injection, it is not going, then let's take it to OT or do whatever it is. So important thing. However, if you have given 2 or 3 injection and patient is not responding, then we have to be ready with the mobilization to taking into operation theater. Tranexamic acid has come in a big way with the women trial, and in my long journey of Foxy, actually, I feel very nice because the initial trial we have listening at the FIGO and in the Foxy conferences, and now this drug is a considered very good prophylactic and the drug which can reduce the mortality and criticality from the PPH. It is a 1 gram IV within 10 minutes it has to be given. So this is the PPH bundle which says that it should be given early in PPH. So first dose, then after 1 hour you can repeat the dose, but after 3 hours it is not going to be useful. It can be sometimes harmful also. One word of caution to everybody that tranexamic acid ampule and the bupivacaine ampule is the looking same. And this is the paper right from 2020 from Anesthetic Journal that there has been the potential at fatal administration of tranexamic acid because they used as the bupivacaine. And in our National Medical Council also we have certain cases where tranexamic acid inadvertently was given as a regional anesthesia. So I will say that we have to be careful, keep always magnifying glass, and always be careful of all the injection which are resembling. Blood transfusion when the HB is 7 gram%, if it is moderate to severe PPH, it is ongoing hemorrhage, you have to organize for the blood component. Whenever there is a pre-existing pathology obstetric which can cause coagulopathy like abruptio, severe preeclampsia, HELLP syndrome, IUFD, amniotic fluid embolism, you always consider coagulopathy. We can have all the coagulation parameter, but in most of the setting, it takes around 1 to 2 hours to get back the result. So the bedside test is still like we can say in all setting, be it a small city, be it a big city, everyone can do it. You need simple test tube and a blood collection, and you can like put it, you see it's strong, how many times, after how many minutes the clot is formed, it is strong or not, and it will give you a very clear picture. And Dr. Nalini Mishra has presented her article has been published for is that how this simple point of care test give you approximate fibrinogen level. A second thing, that the massive blood transfusion start after 2 or 3 units of the blood PRBC. It is not so that right from very beginning you give fresh frozen plasma. It start after 3 to 4 units of the blood, and then it is either 1:1:1 or 2:1:1. This is the parameter we want to achieve: HB more than 8, platelet count more than 75 lakh, and a good fibrinogen more than 1 gram. Always be ready with the PPH trays. We have to be known, struggle with the, like this instrument is not there, bigger instrument is not there, vaginal detector we have only 2, 4 sponge holding forceps, 1 is locked. So this is very, very important, because time is the thing in the PPH. Always record, always communicate every time what we are doing, what is the thing. And I've been our center hospital with the Maneta Center Skill Enhancement, and this is that how we train paramedical at any place in a virtual era, that what we have to do when you encounter the PPS. So your nursing staff is all very all your nursing staff is well versed in it. Always treat the cause, retained placenta, MRP inversion, then you have to treat the inversion and the laceration. Always a little bit about the basic issue, basic obstetrical maneuver, that is bimanual uterine compression, how we have to have the clenched hand in the anterior fornix, thumb inside. SR cannula today, Samartha Ram is not with us due to his some commitment over some place, but his cannula is a very, very simple measure which has been working on the physiological principle of the contraction and retraction, and we have found all over very, very good result of SR cannula. It has the uterine hole and the cervical hole, and it works, it reduces the PPH very, very swiftly. When to patient to be shifted to OT or not, when to hysterectomy is taken, you take hard decision, because leader have to take hard decision. Good technology for the cervical tear repair in difficult situation, how you have to push the uterus low, how you have the different size of speculum, you can have the traction, you can start from below in difficult situation. Wonderful innovator, Dr. VP Pelly, transvaginal uterine clamp, you can push from the below. It gives you time for reduction of hemorrhage. It can cure also. You can transfer the patient transvaginal uterine clamp in utero. So his transvaginal uterine clamp and the aortic clamp are a wonderful innovation which have been usable, which has been effective in our setting, and it has been recognized world over. Balloon tympano, Dr. Nalini is going to happen and going to take, and whenever there is recent placenta, important thing is that you have to mobilize in right time. So what Ian Donald says, the real difficult part about MRP is decision to undertake it. Always look for the all coagulopathy, thrombocytopenia. Now patient are having dengue, malaria, viral infection, Epla syndrome. So we have to be careful about coagulopathy. Last slide, when you want to open the patient for the operation theater, patient profusely bleeding, unstable, hemodynamic, indefinite contour of uterus, like you feeling it is a broad ligament hematoma, uterus rupture, you have to take very, very quick and the early decision. Only in what is the demand of people, that whatever to be done, it has to be done in the first 2 hours. So all these things, bimanual compression, aortic compression, use of non-enzymatic anti-shock garment, these are the things when we can use in the severe hemorrhage. We have to develop skill and drill. For this we are here. So finally, we have to save lives. It is our mission that every person is well-versed, confident in dealing with the postpartum hemorrhage, take good decision, we have a good team of the friends, good team of the people who can do all the things, and if the surgery is needed, you have to do in a right time. So if you can fill the unforgiving minute with the 60-second birth of distance, run, it cannot be more true than the postpartum hemorrhage. And with this, I seek everybody's blessings and good wishes for my upcoming Foxy presidential election in the month of August. Nominations are on. I request all president and secretary that you please nominate me as your Foxy presidential candidate, and we have a combined vision to go together. And this is the big coming together is a beginning. And only when we include everyone's expertise and experience, only then we can do something good for our country and for our fellow, the obstetrician and gynecologist. Thank you very much.
Thank you.
Sir, you're
Hello.
audible. Yes, sir. You're audible,
Thank
sir.
you. You're audible. Thank you, Dr. Sadhana Gupta. She explained very nicely everything. But I think you have to keep in mind that any patient can have a PPH. That is the main thing. An IV drip with a big cannula should be in, and carbotation should be used in regular all the patients. And that is the miracle drug which can prevent the PPH. And she explained everything, nothing to add. Thank you very much.
Thank you, sir.
Dr. Malik. Malik, sir.
Thank you, madam. We have described everything very elaborately and left very little left for us to add. Actually, you have tried to impress the already practicing obstetrician that how important it is. So, madam, thank you very much, and I wish you again a very successful candidature as president. Thank you very much, madam.
Thank you, sir. Thank you.
I thank the chairpersons, Dr. Malik and Dr. Sushanta Kumar Das, for their valuable inputs. These
Thank
are the
you.
pictures. Sadhana, madam, your pictures of AICOG.
Thank you. It was a wonderful AICOG conducted by all Bengal societies, the Jobber and the Kali Mata Mandir, and a lot of interaction. And what is the beauty that is the Galiara galleries were so artistic, so much pointing of the Bengal's culture and great legacy right from Vivekananda to Mother Teresa. And this was something of lifetime experience what we had in AICOG, which was so unique. So that is the Mashmi. Thank you for keeping this memory alive. This is such a great pleasure to again seeing it. Thank you, Mashmi, for it.
Thank you, madam.
Thank you, madam.
So, moving to the second session, it is on refractory PPH skill demonstration by Dr. Nalini Mishra, madam. We have two chairpersons, Dr. Shankar De. He is an NT-scan expert from UK, practicing obstetrician, gynecologist, and sonologist, co-owner of Ultra Clinic Fetal Medicine and Fertility Center, and secretary of Asansol Society. Welcome, sir. Dr. Neel Ratan Shah, he has done his MBBS, DGO, MD, and FICOG. He is the associate professor of MGM Medical College and LSK Hospital, Kishanganj. Founder member and president of Malda Obstetric and Gynecological Society, academic chair of Malda Society for consecutive years, and president of IMA Malda 2010 to 2011. So may I request Neel Ratan sir to please introduce Nalini Mishra madam. Dr. Shah sir, please introduce madam and start the session. Or Dr. Shankar Kumar De.
I think Mashmi, the CV slide is there. So
Dr. Shah, you just unmute yourself.
no,
They have to unmute. They have all joined. Dr. Shah, Dr. De.
Dr. Shah, just unmute you.
Both are not there.
I can see Dr. Shah is there. Sir, please unmute yourself. Sir, unmute Korun.
He's like me, not very expert. Huh? After struggle, I got it.
Shah sir is speaking, but we are not able to hear. He's talking.
Yes.
Yes, sir.
Yes. Yes. Okay.
Yeah, now.
Welcome,
Yeah.
Dr. Nalini Mishra, our speaker of the session, and I congratulate the organizer Dr. Sadhana Gupta, the conveners and the coordinators. All. It's a very good, important sessions, and we are facing this problem in our practice, in our career, that it's a burning problem, and we should take it very seriously. Dr. Sadhana Gupta, thank you. You have elaborated it, the PPH measurement and the first line treatment. Now, I welcome Dr. Nalini Mishra. She is MD, DGO, DNB, and MNAMS and FICOG. Dean of Profession, ONG, Ellen Medical College, and JK Super Specialty Hospital, Bhopal, MP. Innovations to credit CG Balloon, innovate low-cost uterine balloon tamponade. CG drop, the innovate low-cost drape of estimating blood loss of the delivery. So innovate low-cost concept to rationalize the transfusion of blood products in PPH. Publicity in JGO FIGO House in January 21. Invited faculty in conference of 150, more than 150, publication more than 50, and citations. And she is the doctor who have invented the balloon, the drape, the innovative cost concept, tamponade. So we should happy to hear from you. Now I give it to Dr. Mishra. Please, you start your session. Hello.
Nalini, Chitakala, you have to start the video of Dr. Nalini.
Yes, ma'am.
Mishra.
Yes, ma'am.
Nalini, are you there now? You can start video. I think some internet issue is yes.
Yes.
I am Dr. Nalini Mishra from Bhopal. Chhattisgarh drape is an innovative low-cost drape which is prepared of plastic apron. This is used for visual estimation of blood loss after vaginal delivery. You can prepare it at the point of care. What we need is a plastic apron. This is very easy to make, use, and can be disposed in the yellow bag, and it detects PPH in real time. It costs around 15 rupees each. The vertically folded plastic apron is taken, and the lower edge of this vertically doubled plastic apron is sealed with the help of a plastic sealing device. It takes only few seconds, and the completion is denoted by the sound of a beep. This lower portion of the plastic apron, which is now sealed, is unfolded in a manner that it forms a cone, as you can see. Cone is used and is denoted at 10.5, 12 and 15 centimeters with the help of a plastic scale, and it denotes the volumes of 350 ml, 500 ml and 1 liter. The neck piece of the CG, this drape is cut, or the plastic apron is cut. Now the cone of this CG drape is folded under the woman who is in the first stage or early second stage of the labor, and the belt which we use to tie the apron on our back is tied in the front of the abdomen of the woman. This forms the lower belt. Now the neck piece which we have cut, the two ends will serve as the upper belt, so that all the blood is siphoned into the cone and does not spill here and there. After the baby has delivered and amniotic fluid has drained out, we ask the woman to lift her buttocks a little, and we unfold the cone like this. Then the whole blood after the delivery of the baby is collected in this cone or pouch and can be measured in real time. You can dispose this CG drape in the yellow bag along with the placenta and other tissues. If the woman is having a tonic PPH not responding to medical management, we have to go for the second bundle, and intrauterine balloon tamponade is an important component, And when do we use the UBT? When the obstetric shock index has crossed 1 but is still less than 1.5 is the ideal time to use this. So I'll be describing two devices. One is Chhattisgarh balloon and another is easy balloon. Chhattisgarh balloon has a central drainage port, whereas easy balloon is more of a conventional condom balloon tamponade. So how do we make Chhattisgarh balloon? We need a Foley's catheter with a bigger French, condom, scissors, 2 syringes of 10 or 20 ml each, cell line, and we prepare it in all the aseptic precaution from the steps A to F, A, B, C, D, E, F. So A is for air, remember A for air. So introduce air with the help of a syringe and inflate the bulb of the Foley's catheter, and then it is wound round over another finger so that the shaft is out of the way, because we are now perforating the bulb of the Foley's catheter, and this perforation is extended all around the circumference of the Foley's catheter. So now we have resected the bulb and the cut ends are everted up and down. This will expose the hole on the shaft of the catheter in the area of the bulb. Now we are moving to B. B is to make the bulb. So we are replacing the bulb of the Foley's catheter with a bigger bulb which is prepared of the condom. So roll the condom over the catheter. Now we come the C. So C is cutting 2 rings from the urinary drainage port. At the end of the urinary drainage port, prepare 2 rings just like rubber bands. Now this was C, and D is double application of these rings. So first of these ring is applied in the upper portion of the exposed area of the bulb, so in the neck. Then the second ring is taken and it is applied in the lower portion of the condom, 1.5 to 2 centimeters away from the rim of the condom. So this is double application of the ring. Now comes the E. So we have to excise the tip of the condom and tip of the catheter together at the level of middle of the urinary drainage hole. This will create a hole at the top. This is then in this CG balloon is then dipped into the betadine solution for at least 3 minutes. We cut a bottle of normal saline like this and expose. You see in the CG drip the blood loss is more than 1 liter. OSI must be more than 1. Expose the cervix with the help of 2 big speculums. Always keep big speculums in your PPH tray. Then catch hold of the anterior and the posterior lips of the cervix and take out the Chhattisgarh balloon from betadine. Keep it in between your 2 fingers and insert inside the uterine cavity. It goes very easily till the rim is reaches the level of the upper portion of the os. After that we are going to pack the vagina with a big dressing pad or an autoclaved pad. This is done, and after that the urinary drainage port will be connected with the urosec, because this will be draining the blood which is going inside. You can see the blood which is inside the uterine cavity is now can be seen in the tubing of the urosec. Since we have replaced the bulb of the Foley's with a bigger bulb made of condom, so we have to inflate it through the bulb inflation port. So take the syringes alternatingly, and one person fills the syringe, another person inflates the bulb through the bulb inflation port, and this is done till either the resistance is felt or the column in the tubing stops moving. So that is the hemostasis. So once the hemostasis is achieved, we can now proceed further. You see the nicely inflated bulb inside. Then we catheterize the bladder, mark the margins of the uterus, and then put her on oxytocin drip, give her antibiotic. Of course, you can prepare the CG balloon. There are many advantages. The bleeding can be assessed through the drainage port connected to the collection bag, and you can pack the vagina. So it takes care of the expulsion of the UBT, which is the biggest problem in conventional condom balloon tamponade. you can always prepare CG balloon in advance and get it ETO'd and then keep it ready for use in case you are forgetting these steps or there is no one and suddenly the emergency has struck. So anybody can make a very easy variety of condom balloon tamponade, and that is easy balloon, that is really easiest to make. There is nothing much in that, it's more of a conventional condom balloon tamponade. So again, take any size of Foley's catheter, prepare 2 rings. This 1 millimeter ring is cut from the end of the urinary drainage port. Then the condom is rolled over the Foley's catheter, the tip of the Foley's being in the tip of the condom. Then take 1 ring and apply it 1.5 to 2 centimeters away from the rim of the condom. So this 1 ring is applied twice, only do it twice. So this is done. So it's how easy it is to make the easy balloon. After that you dip the UBT which we have prepared in the betadine, expose the cervix with the help of 2 big speculums and catch hold of the anterior and the posterior lip of the cervix with the help of 2 sponge holding forceps. Now take out the easy balloon from the betadine and then insert it inside the uterine cavity. It again goes easily till the rim of the condom is visible in the upper portion of the internal os. This must go as at least this far in, and we have to visualize the bleeding at the level of the internal os. Now how do we inflate it? We have to inflate it through the urinary drainage port by connecting an IV set to it and IV normal saline. So the saline goes through the catheter into the bulb of the which we have prepared in the by inserting the condom over the catheter. So the saline goes easily and you have to do it till the bleeding stops. Once the bleeding stops, now we have to occlude the distal portion of the Foley's catheter. So that is done by folding it and applying the second ring 3 times over the folded lower end of the Foley's catheter. Remember it, we have to do it 3 times so that the fluid doesn't come out and the UBT is not deflated before time. Once this is done, check the bleeding again, it is stopped, and then take out the speculum and pack the vagina with a big, again with either a big sponge holding, big dressing pad or a big autoclave perineal pad. So then mark the margins. When we have to deflate it, just pull out the 2 ends of the Foley's catheter, the ring will just get away, and this can be done 6 to 24 hours later. When we talk of CG drape, CG balloon or easy balloon, these are all the local innovations and can be prepared at the point of care. There is nothing commercial about it. I'm proud to be Indian. Thank you so much.
Nalini Mishra, madam, yeah.
Yes, somehow it got connected in the middle.
And Nalini, your video right from the beginning. So I think you can give your 1 or 2 comment before we go to the chairperson for their expert. Anything.
Madam, can you hear me?
Yes, you are on.
Okay. So it played from the beginning, I think. So so first of all, Sadhana ma'am, thank you. Always, I thank you so much for making me the part of this noble cause, so that I can take my innovations to everyone. And as I said, there is nothing commercial about it. You have to prepare it at the point of care and use it. CG drape costs only 15 rupees. So you just have to invest in that plastic sealing device. And even a staff nurse can make it, and it diagnoses PPH in real time and very quickly, and very environmental friendly also, because you can send it for incineration along with the placenta in the yellow bag. So that is it. And you can make anything CG balloon, or if you want a drainage port, Otherwise, easy balloon is the easiest to make. It's more of a conventional condom balloon tamponade. So it's a second line intervention. And whenever you think that the bleeding atonic PPH is not responding to medication and first response bundle, then please go for the second response bundle. It is evidence-based. All the guidelines in the world, right from RCOG, FIGO to Indian guideline, they all recommend condom, this balloon tamponading as a second line intervention. Because it is really effective and it doesn't depend upon the electricity or anything, and it's very, very easy to make at the point of care. And the safety profile is very good, and efficacy is nearly 95%.
May I request Dr. Shaha for his remarks?
Thank you, Dr. Mishra. You have described the two balloon tamponade and the drapings and all.
Yes.
But your subject is refractory PPH. Dr. Sadhana Gupta is already mentioned the first line of treatment.
Yes, sir.
Now, she also mentioned another thing, that is perforated cannula, which
Yes.
I have a personal experience with this cannula. If you put that, whole body is perforated with the cannula. And if you put it within the uterine cavity after vaginal delivery, whole cannula is there and it will suck all around the cannula, and so the both of wall of the uterus is coming each other. So you have enough time to observe and enough time to take further decision.
Yes, sir.
That is the she has already mentioned there. And when you will go the surgical intervention where it fails in refractory PPH. How you assess?
It is a question to you, Nalini. I think
Yes,
it is a question, sir, that how
Yes,
you
sir.
assess that.
Sir, when you see, sir, as per the different guidelines across the world, you have to go for the conservative measures till the obstetric shock index is between 1 to 1.
Hello.
I
Hello.
think she lost her connection again. Nalini. So
Hello.
she was, hello.
Actually, when we'll go
Lost
for
her.
next session is there
Yes,
for
yes.
surgical intervention.
Yes, I think
But
she
our
lost her.
session is ends here to manage the before surgical. Thank you,
Thank you.
Dr. Mishra, for
Thank you.
very good presentation and your innovation of the cheap and handy tamponade and the draping, so everyone can use it in their, if they see the video, use it in emergency where it is the normal tamponade or the balloon or they are not available. Good.
Thank you, sir.
Thank you.
Thank you, Nalini Mishra, madam. We now move to session 3. It is on surgical management of PPH with video by Dr. Sashi Kabra Maheshwari, madam. We have 3 chairpersons. Dr. Amitabh Pal, he's a professor under West Bengal Medical Services. He's also paper setter and postgraduate examiner under different universities and DNB courses. He is the honorary secretary of Bardhaman Obstetric and Gynecological Society.
Anshul ko bulaiye.
Dr. Malik, next chairperson. Next slide, please. Yes, Dr. Mangal Prasad Malik is currently working as consultant and obstetrician in Midnapur, and he is the secretary of West Medinipur Obstetric and Gynecological Society. We have Dr. Ratan Kumar Das with 20 plus years of experience. He's the director of CTVS and the first surgeon to perform successful double switch procedure in 2009. He's the first surgeon to successfully perform CABG and areas of interest is in off-pump CABG with techniques. So may I request Dr. Malik to introduce Dr. Sashi Kabra, madam. Dr. Malik.
Hello.
Yes, yes. Dr. Malik.
Am I audible?
Yes, yes, you are audible.
Yes. It is a really good session, and it is my honor and privilege that to introduce Madam. She completed her MD, and she's FICG, FCS, FMS, a long list, and also she did her deep MAs in minimal access surgery, and she's senior specialist OBG and NB teacher. She worked at DDU hospital and also attached with for Delhi Health Services, and also worked as president Delhi Gynae Forum Southwest, and also very significantly she is now the chairperson of PCPNDT committee West District Delhi. That is very now very important aspect of our day-to-day practice. Madam, you are welcome, and please proceed your slidings. Thank you once again for inviting me as a chairperson.
Thank you, Dr. Malik. So Dr. Madam has actually made the video with lot of effort, but she has a personal reason and she could not join her daughter's convocation. She has gone to Bombay to join for her daughter's convocation. So I request Chitrakala to play the video for us.
No, you will like give salient feature of it. You give this thing, the voice to the video.
Can you hear me, ma'am?
Yes,
Yes,
madam.
yes.
Okay, you play. I'll try to.
Yes.
Because sometimes this net is creating problem.
You go on. So she has dissected through the broad ligament, so you can, yes.
Okay, so this is a video of, I think, internal iliac artery ligation. Hello?
Yes, it is internal.
Yes, madam. Yes.
Ligation. So she is dissecting the leaf of the broad ligament. And is it playing?
No,
It's not playing, no?
not playing.
Not playing. Now it is playing. Yes. So she has described that this patient has been bleeding and refractory bleeding. So now you can see she has dissected the peritoneum, the posterior peritoneum, and then she is showing the vessel, and the ureter is in the medial fold. Always ureter has to be in the medial fold, and now she is trying to show the Y of this. Can you see the Y? So common iliac artery at the level of the sacroiliac articulation, it divides into external and internal iliac. The apparently continuing branch is the external iliac, and the branch which comes medially is the internal iliac. So she'll be now dissecting the sheath over the internal iliac vessel. So you can see the Y, and you always have to confirm the Y. And then the sheath she'll be dividing, because unless you divide the adventitious sheath over the artery, we cannot pass the instrument below the vessel. So she's taking the help of a mixture, and with the mixture she is lifting up the tissue over the vessel, and only that portion where she has to expose the internal iliac artery, and not in the whole length. So that area is about 2.5 centimeter to 3 centimeter below the bifurcation. So you see exact, I think it is stopped.
Kala, you see, please, further. Chitrakala.
Ma'am, sorry, ma'am.
Chitrakala, it is done or it has remained?
Ma'am, only that much video I received, ma'am.
No, that was not. So I'll complete the remaining. Madam, then for everyone to see that how to approach the internal iliac is just for PG students. So you just put your hand inside the pelvic cavity, feel the sacral promontory, go to the sacroiliac articulation. If you can't remember any other step, then go to sacroiliac articulation. You will feel the pulsation. So you'll feel the pulsation and just divide the peritoneum over that and go vertically about 10 centimeters. And then you will see that the common iliac artery divides into external and internal iliac, and about 2.5 centimeter below the division, you have to expose, as was shown in the video, that you divide the tissue over the internal iliac artery in that portion only of about 1 centimeter, and then you pass the mixture from lateral to medial. And it is always better to do it on the right side first if you are a right-handed person. So pass the mixture from lateral to medial, and always keep a vicryl folded, just like a loop, and then take that loop in that mixture and pull it out. Then divide that thread into 2 portions and tie. We don't have to dissect, only tie the internal iliac artery at 2 places. Always confirm by feeling the femoral artery that by mistake we have not occluded the external iliac. So we have to go down so that we ensure that we have tied the anterior division of the internal iliac artery. So always do it on both the sides, and it helps tremendously. It reduces the pressure or flow pressure in the vessel, and it helps the coagulum to form. So everybody must learn the art of internal iliac artery ligation, because as Sadhana madam was saying, that because of the increasing number of cesarean section, placenta accreta syndrome is becoming more and more common. So we are likely to encounter massive hemorrhages, and everywhere we don't have the facility of intervention radiology, and that too, the guidelines are not very clear. So we have to learn the art of ligating the anterior division of the internal iliac artery. And madam must have also sent the video of uterine artery ligation and this anastomotic branch of the utero-ovarian branch. So this is the stepwise devascularization. First of all, uterine artery ligation, and then the anastomotic branch of ovarian in the broad ligament near the meso, salpinx. So that is the stepwise devascularization. Because the video is not there, so I'll stop here, I think. Hannah, madam.
Thank you, Nalini. Actually, we really regret that what video we had a little bit like left out. So Nalini have taken few things, and Dr. Ram Prasad and the senior person, Dr. Ratan Shah. So we will like to have a little bit regret that we could not complete the video, but we will like to have comment from the senior person who have a good like expertise in it. So Dr. Shah, Dr. Sindhu Bala is with us. So like to have your comment. Just a minute, Chitrikala, we want to have a discussion. Maushmi? Yes. So Dr. Day is there. Yes,
Hello.
Please. Yes, please.
Hello, I am Dr. Amita Bhopal, Secretary of Bardhaman Obstetric and Gynecological Society.
Welcome.
I was
Welcome,
the first
sir.
chairperson. I was the first chairperson of this session, but unfortunately, unfortunately, my internet is off when just this session started. So first of all, I want to say that at the beginning, we don't go for internal iliac artery ligation. Nowadays, compression suture for prevention of PPH is very much important. Regarding compression suture, I can tell you the peeling suture, and there are so many compression sutures. We will first try that one just to reduce the surface area so that the bleeding will be stopped. Number 2, we will go for then if it is not controlled. But one thing is important, before giving any compression suture, I will have to give compression of the uterus. If after compression, whether there is any bleeding or not, if after compression bleeding stops manually, then and then only I will give for the compression suture. This is most important. And number 2, which is very important, as a second step, if the compression suture fails, then we will give the selective devascularization of both sides. That is uterine artery of both sides and ovarian artery of both sides. And lastly, when everything fails, then before hysterectomy, we go for internal iliac artery ligation, because there are so many advantages in compression suture, because it is not risk free. Internal iliac artery.
टेलीग्राम पे मैम ने भेजा था, तो मेरे पास एक ही वीडियो है तो.
Hello.
Yes, yes, sir, please. Somebody was unmuted actually. Sir, please
Because
go on.
internal iliac artery ligation is not risk free. It can damage the internal iliac vein. For that reason, as a primitive measure, as a primary measure, we can go for compression suture, madam.
Thank you, sir. Wonderful input, because compression suture is the way that it is doable, and modified bead inch is very, very easy to do. You just have to put on the shoulder. And again, the pulse of wisdom that you have to see that if the compression is causing the stoppage of bleeding, only then we should go ahead with the compression suture, otherwise not. So Nalini, you wish to say something?
Yeah, ma'am, this actually the video of internal iliac started showing. So we started with the internal iliac artery, but as sir rightly said, we have to go like that. First the medical management, then the conservative things, and as per the second bundle, then if we have to go for surgery, all types of compression first, definitely compressions first, and then stepwise devascularization, as sir rightly said. First the uterine artery of both the sides, then the anastomotic branch, and as the last resort for internal iliac artery ligation. And if nothing is working, we have to take the decision for hysterectomy fast. Means we should delay our decisions for hysterectomy in order to save the uterus. Rather, we have to save the woman. So thank you, sir. Thank you so much.
Thank you. Thank you.
Thank you. Thank you, Nalini madam, and excellent participation and inputs by chairpersons. So we now move on to the next session of panel discussion. I hand over the session to the co-moderator, Dr. Ayushi Agarwal.
So thank you, ma'am. Ma'am, am I audible?
Yes, yes, Ayushi.
Thank you, ma'am. So we begin with the session 4, which is a panel discussion on difficult case situations in postpartum hemorrhage. So I take my privilege to invite our moderators, Dr. Maushmi Das Ghosh ma'am and Dr. Sarita Kumari ma'am. Dr. Maushmi Das Ghosh ma'am is a consultant at Tata Main Hospital, Jamshedpur. Ma'am is an active member of Jamshedpur Ops Gynae Society. Ma'am has organized first All Jharkhand Conference. Ma'am is a postgraduate teacher and guide and Foxy Awardee of Kamini Roy Orator East Zone 2017, Indumati Jhabri Award, Bani Samanta Award. Ma'am has contributed to Foxy and ICOG publications and chapters in textbook. Warm welcome once again, ma'am. Dr. Sarita Kumari ma'am. Ma'am is a consultant in Tata Main Hospital, Jamshedpur, working there since 2011. Ma'am has worked in ICMR malaria research project in pregnancy for 1 year. Ma'am is awardee first prize in All Jharkhand Annual Conference in Bokaro Steel City. Ma'am has 3 international and 2 national publications. A warm welcome, ma'am. Next, I would like to invite our expert panelist, Dr. Priyanku Roy, sir. Sir has been assistant professor at Lord Buddha Koshi Medical College and Hospital, Saharsa. Sir is a consultant in fertility specialist and gynae endoscopic surgeon at Roy's Clinic Ramakrishna IVF Center. Sir is chairperson Public Awareness Committee Foxy, vice president WETOC FITO, member Contraception Committee, PIGO member Scientific Program PIGO World Congress. Sir has many publications, more than 75. And authored many books. Sir, we can see a list of awards. Sir has got gold medal for topping in MSc University examination, Foxy Korean Award, Foxy Future Award, and many more. A very warm welcome, sir. Next, I would like to invite our panelists, Dr. Sutappan Samanta, sir. Sir is a consultant gynecologist and infertility practitioner at Indra IVF since 2017. Sir has got a fellowship in reproductive medicine and surgery with special interest in fetal medicine. Sir has got Torrent Young Scholar Award 2015. Welcome, sir. Dr. Smita Das Ghosh, ma'am is obstetrician, gynecologist, colposcopist, and gynae endoscopic surgeon. Ma'am is the winner of Best Paper Yuva Foxy 2012, New Discon 2013. Ma'am has pioneered paper on prevalence and distribution of cancer cervix among women of Northeast India, editor, Rotary Club of Siliguri, Medics. A warm welcome, madam. Dr. Sabyasachi Ray, sir. Sir is a professor in Department of Obs-Gynae at Midnapur Medical College and Hospital, West Bengal. Sir has created past secretary of West Midnapur Obs-Gynae Society. Sir is a fellow of Indian Council of Obstetrics and Gynecology, has many publications in national and international journals. Welcome, sir. Dr. Dipankar Mandal, sir. Sir is assistant professor at Shishu Medical College, has been assistant professor at Shishu Medical College, running IVF center for the past 3 years. Welcome, sir. Dr. Amit Datta, sir. Sir is a consultant obstetrician and gynecologist at Bardhaman. Welcome, sir. Dr. Atin Haldar, sir. Sir is a professor at Bardhaman Medical College, EC member Bardhaman Obs-Gynae Society, published more than 50 articles in international and national journal. A very warm welcome, sir. Dr. Sindhu Bala, ma'am. Ma'am is a clinical director, creation, the Fertility Center, Siliguri, and consultant Obs-Gynae at Arogya Niketan Nursing Home. A very warm welcome, madam. So I hand over the session to Moshmi, ma'am, and Dr. Satya Kumari, ma'am. Thank you so much.
Thank you, Ayushi. So is the screen visible?
Yes. Yes, ma'am. Yes, ma'am.
So welcome, dear panelists. So we look forward for a very interactive panel. Do we have Priyankur Roy with us, the expert panelist? Has he joined?
Yes, Priyankur has joined.
Okay, okay. Yes. Thanks, Priyankur. I think recently I saw in Facebook you have been promoted to associate professor. Here it was written assistant professor.
Yes, ma'am. No problem. Sure. Thank you, ma'am. Thank you, ma'am. Thank you, ma'am. Thank you, ma'am.
So just two introductory slides on PPH. PPH is responsible for 25 to 30% of all maternal deaths worldwide. It causes about 100,000 maternal deaths per year worldwide. And traditionally, as we all know, it is defined as blood loss more than 500 ml during vaginal delivery and more than 1 liter during cesarean section. Any amount of bleeding after childbirth, which has the potential to deteriorate maternal condition, can cause maternal instability and shock. Primary PPH is within 24 hours and secondary PPH is after 24 hours to 6 weeks postpartum. Golden hour is the time in which resuscitation must begin to achieve maximum survival with arrest of bleeding. And causes of PPH, we all know, 4 T's, stone, trauma, thrombin, and tissue. And it is always possible that 2 reasons can also coexist. And this PPH tests the functioning of healthcare system and the skill of healthcare workers, as it is often unpredicted and present like a thunderbolt. The patient can deteriorate very rapidly after onset of PPH and can die in a short span. So obstetric hysterectomy, admission to ICU, and massive blood transfusion, they're all classified under severe acute maternal morbidity. So every mother counts. So moving to the first case, a very common scenario in obstetric practice. So as we follow the dictum, the common things to be discussed first. 38-year-old primary gravida, DCDA twins, conceived after IVF treatment, admitted in labor at 35 weeks of gestation. At 9:30 p.m., PV was done. Cervix was fully effaced, 3 centimeter dilated. Liquor was thick meconium, head at -2, and pelvis adequate. Ultrasound showed first cephalic and second transverse lie with good fetal weight more than 2 kg. Cesarean section was done at 10 p.m. Intraoperative period was uneventful and both babies were doing well. So can I ask Dr. Sutapan Samanta, what preventive measures will we take in this case to prevent PPH? A common, Dr. Sutapan Samanta or Dr. Sindhu Bala, I can.
Yes, ma'am. Yes, ma'am. Since this is a twin pregnancy, we have to ensure that when she gets admitted, even prior to delivery, she has adequate hemoglobin. It can be done either giving iron transfusion or blood transfusion, or even with proper oral hematinics also. We must ensure that she has proper hemoglobin, her coagulation profile, her liver function test, all must be assessed. And since she will be like such kind of patient usually go labor preterm, as happened in this case. So we must ensure blood in blood bank. We must book blood for her. And during the time of admission, we usually keep blood in the fridge near the liver room, even in the OT during cesarean time, because such patients have over-distended uterus. They may have atonic PPH, considering her age and good size of both the babies. So we'll ensure that her hemoglobin is all right, blood is arranged, OT people are informed. We should be apt to give carbitocin if there is no contraindication just after the delivery of the second fetus.
So oxytocin, routine use of oxytocin, as she's a high-risk patient.
Yes, ma'am. That has to be, even I will not hesitate in giving carbitocin in such patients.
Post IVF pregnancy, 38-year-old mother with twin pregnancy. So we have given her oxytocin. We have taken that her hemoglobin is optimum, and now at 12 a.m. sister is calling for PPH. When we assist her, she's having mild pallor with tachycardia, pulse rate of 130 per minute, blood pressure 100/70. On examination, uterus is atonic, and she's passing clots, and bed sheet was partly soaked with blood. Can I ask Dr. Sabyasachi Ray, your approach now to manage this case?
Yes. Basically, it's a case of primary PPH. I'm audible?
Yes, please.
Okay. So it is a case of primary PPH. So first thing, the patient is having pulse rate, tachycardia, and BP is going lower down. First of all, I need some help. I must have to ask people to come to help me, because anybody only cannot save the mother if there is a massive PPH or something else later on. So call for help is the first things, and definitely I go for a resuscitation and check the BP and pulse frequently, and resuscitate by giving the fluids, in intravenous fluid, that is the crystalloid fluid, and inject we have to give, and arrange for the blood. And also, if I have a in setup where hemoglobin can be done immediately, we should ask for the hemoglobin and coagulation screen also. So we have to give uterotonics, injection tranexamic acid also, and we can make sure that the uterus is contracted or not every time. And also we give the stepwise uterotonics should be given to this patient along with tranexamic acid. First of all, we give the oxytocin 10 units in 1 liter of fluid and 60 drops per minute at first, and you increase the dose accordingly. If it is not acts, then we ask for the prostaglandins, and also we give the misoprostol repeat dose. So if the patient the bleeding response, the patient stop bleeds, then it's well. Otherwise, we again think for the balloon tamponade, particularly this type of patient, and transfuse the blood as early as possible.
Yes, thank you very much.
If I can just add on a point, if you don't mind.
Yes, please. Yes, Dr.
Yeah. So basically, like perfectly as sir has already mentioned, all the things that we have to do initially, of course, is to assess. But one of the important things, ma'am, I would just like to add is usually what happens is the patients in whom we sort of predict PPH will happen, the chances of PPH are the least are the patients where we usually land up in PPH. So that is why the prediction and this thing of PPH, I think we have to be ready for every patient can go in for PPH is one thing that we have to sort of remember and we have to think of. And the second thing that I would like to say over here, ma'am, as you said, like Foxy has come out with a brilliant program with the Manyata program that has been going on across the country. And in that, we of course talk of different protocols, different things that can be used. And I just wanted to mention one point in addition to what Dr. Sabyasachi has just said, is that the auditing that we have written at the end is a very important point, ma'am, because it's important to know in our hospital how many patients are supposed going into PPH, or if something is going wrong, because in today's day, oxytocics are so good, especially oxytocin, carbitocin, etc. They have come in so well that you know, sometimes when we have in a week, suppose 2-3 patients who are not working well, we'll have to, of course, in the back of the mind, run whether the drug is of its good potency or if it's not of its good potency, because sometimes when the cold chain is not maintained in oxytocin, such a problem can happen. So that is something else that we need to think of, audit it well, and suppose in case in a week, 2-3 cases it has happened, so we might as well change the batch of the drugs that has probably come to us, is something also that we might do.
Madam,
Can I add one thing? Dr. Priyanku, can I add one thing?
Hello, I'm Dr. Halda speaking. Hello.
Yes, Dr. Halda. Can we move on to the next? Shall we finish this case?
Yes,
Then we can put in our inputs.
In this case, ma'am, we need to evacuate the uterus also. We must get rid of all the clots which has accumulated inside that atonic uterus. That part must not be like forgotten.
Okay.
No, madam, just one one thing I want to add. Whenever any PPH is there, you must do one extra channel before doing anything. This is mandatory. If suppose you are predicting PPH, if you do not do anything, you do a channel extra, then you start your management.
Yes, agree. Thank you very much.
Also,
So
if I could add one thing, actually, here, like we just discussed, that it was a cesarean delivery was done, and after 1 hour we got a PPH call. But at this time, I would expect my patient to still be in the OT, actually, in the post-operative stage, so that we could utilize golden hours to its best. And so, as a protocol in patients in whom we are expecting PPH, it is always a good practice to keep the patient and not to shift the patient to the ward for the first 1 or 2 hours.
No, the cesarean section was uneventful. So after cesarean section, in the post-operative period,
we
the
keep
PPH
the
was
patient for 1 to 2 hours, instead of shifting to the ward sooner.
So every patient cannot be kept in the operation theatre. Suppose you have back-to-back cases. So cases have
no,
to be
ma'am,
moved down to the post-operative ward.
No, because we were expecting a PPH in her, no? Because she is a patient in whom you can expect a PPH.
Okay, taken. So now,
yes.
This patient, when we estimated the blood loss, it was around 1 liter. She received 2 Paxils. We gave her all the oxytocics. We gave her Tranexia injection, and we have also put in our intrauterine balloon tamponade as discussed by Nalini madam, as uterus was intermittently becoming flabby in spite of the medical management. So medical management along with balloon tamponade was done for this patient. Now again at 2:30 a.m., the patient is having pallor with increasing pulse rate, blood pressure 94/66. Uterus is again atonic with blood loss. So now what will be the next line of management? Dr. Haldar?
So already patient is failed medical management. I think
Yes.
she has been given all tried for all medical approach. That means oxytocin and the carbitocin or the prostaglandins. What the medical?
So medical management done, balloon tamponade done. So next.
So next we have to approach for surgical management,
Yes.
take the patient to the OT, and definitely we'll initially go for compression suture first. If compression suture fail, then we have to go accordingly. So compression suture actually it is done very well. Now we can go for B-line suture. Here already cesarean section has been done, I think. So we can go for the Heyman suture, or that will be better. If not respond, we will definitely wait in the OT, at least as per the guideline that you see the blood loss. If it is continuing, bleeding is there, as already uterus is closed. So you have to see the vaginal bleeding. If vaginal bleeding stop, then we will definitely take out the patient from the OT. Or if not, then ultimate resort is the hysterectomy. I think compression suture is the initial treatment for this particular case.
Yes, very correctly said. So now comes the role of 5th T, the surgical management. The patient is shifted to OT and the senior obstetrician available at that period of time should be involved. Compression sutures, as we all have discussed earlier, should be first tried. followed by selective uterine devascularization. And early decision for hysterectomy should be taken. Blood transfusion protocol should be followed. And if required, the massive transfusion protocol should be activated in the blood bank. So will, skill and drill of every healthcare worker and obstetrician is important, as atonic PPH, and this scenario is very common in obstetric practice. So there is a mnemonic where H is ask for help, assess vitals, establish etiology and treat accordingly, massage the uterus, oxytocin infusion, shock garment, tamponade balloon, apply compression sutures, systematic pelvic devascularization, interventional radiologist, the role comes wherever it is available, and hysterectomy.
Okay, so one before Maushmi, just I will like to interrupt. I wish to have opinion of Dr. Aten, Sindhu, Dr. Susmita, and Priyakir also. Sometimes you opt for the prophylactic compression suture because we finally had. But if you did twin pregnancy, like any risk factor, and you are feeling recurrent, what happens? Uterus is contracted at time of cesarean. Sometimes it is relaxed, then it is contracted. Anybody who opt for in your practice the prophylactic compression suture, so we are actually not reopening the patient and can reduce. So want you, the expert, like what you do you experience
Yes, ma'am.
this situation?
Yes, ma'am. If we see that during the surgery also, even despite giving all the uterotonics, whether it's initially it was carbotation was not available, so we used to give either prostrodine intramuscular in the myometrium. And if despite all that, if we have a big baby like 5 kilo baby or such kind of overdistended uterus, if uterus is not contracting, getting relaxed again and again, it's better to do the Bill-Lynch suture that and there, that time only. Because in such case, even if it is especially primary patient, preservation of uterus is a must, because it will take a nightmare to counsel the patient about hysterectomy during the first delivery itself. If it is multigravilar, that is not a big issue. But in the first delivery, it's very difficult to make party understand that uterus needs to be taken out. So it's better to do the Bill-Lynch suture then and there, rather than going into the ward and encountering the PPH and bringing to the OT and making ourselves embarrassed in front of the patient party and losing extra blood. Even getting blood is not easy. We can arrange 1 or 2 units, but in massive hemorrhage, we need to have 4, 5, 6 unit FFP, PRP, everything. Yeah. And then it becomes very tedious job for us.
Yeah. So in cesarean, in operation.
Actually, ma'am, rightly said. Dr. Gupta, ma'am, thank you for your good input, because we are practicing in a low research setup. And just for your information, we always do prophylactic Bill-Lynch stitch in somewhere where we do cesarean section when we think that there may be chance of PPH. So it is better to give a Bill-Lynch stitch earlier, then later on to open again and go for a Bill-Lynch stitch. So thank you, ma'am, for your good input.
So actually, yes, Dr. Halder.
Yes. Actually, I prefer not Bill-Lynch. I personally say, because it is a little bit complex procedure, but I hem and suture. That is very easy procedure.
Square sutures.
Yes, I do hem and suture almost, because I am facing Bardhaman, a remote area. So here, most of the patients come to us, the hemoglobin level 8 to 10 gram normally. So I do routinely compression suture, almost 70% cases prophylactically by simple hem and suture.
So thank you for actually why I bring, because I also do sometimes, because it is high risk. So it is really great to have the real time that we are having, like in small cities, not accessible to massive. So very, very important point in high risk situation, if it's especially uterus is intermittent relaxing, you can give. And I also that Bill-Lynch a little complicated, but Heyman's is not a cross suture. It is just you don't have to give the 9 entries, 5 or 6 entries, but you just put a through and like tie on the shoulder. So
and not two suture, only single stitch.
Yes, so this is also single suture. So thank you, because that is the learning and sharing what we want to achieve. Yeah. And tranexamic acid, I will say all prophylactic, the tranexamic in all high risk cases, the prophylactic tranexamic acid is good. And if it is you were feeling that it is unstable, then we can give the repeat dose after 1 hour. So all the high risk cases like DCDA twin this primary, so we can give the tranexamic acid. And what Smita was saying actually, that yes, we cannot keep patient for 1 to 2 hours, but if the patient is a little bit unstable, then don't shift from OT. And always these all cesarean, what is the essential recovery after surgery? The patient for 24 hours need to have a surgical ICU, and they it is desirable that they have all the good monitoring. So very important point from everybody. Priyankur, you are there. Priyankur, your comment.
Yes, ma'am. Ma'am, I just wanted to reiterate what you just said, because ma'am, we all know that maybe we have been trained in the best of institutes, but we need to understand the post-op care that the patient will get right now should decide whether we should take up a patient or not. Because in case because most important is not operating on the patient, but if the post-op place does not allow us to operate a patient, I think it's better to refer the patient rather than get into trouble. Because we all know we used to talk of safe baby and mother, but we talk of a safe obstetrician also in today's day. And medical legally, we have to be first of all very sound, and then only we can afford to take a case. And ma'am, Sadhana, the other point that you made, the tranexamic acid that you talked of, tranexamic acid, we had done a study during my postgraduate days, and we had published the article as well in our Jogi journal. And it was very rightly seen that prophylactically when tranexamic acid was given, it not only decreased the chance of PPH, but it also decreased the third stage of labor duration as well, thus meaning that the chance of PPH was much lesser. So I think that is something else that we can consider. And tranexamic acid in today's day, WHO has also recommended routinely in delivery as well as in cesarean section. It can be given prophylactically as well.
Yes, very rightly said, Dr. Priyanka.
Yeah. So winding up the first case with a good message that whenever there is a prediction of PPH, we take extra precaution. But most important, as PPH can happen with any patient, post-operative vigilance and post-operative care is important. So for this, we now move on to the second case. I request my co-moderator, Dr. Sarita, to take on.
Thank you, Dr. Mashmi. First of all, I would like to express my heartfelt thanks for giving me an opportunity to be a part of this great academic panel. Now moving to the second case, a 35-year-old female, gravid 2, para 1, was, please first slide. A 35-year-old female, gravid 2, para 1, was admitted for an induction of labor at 41 week 3 day gestation. She had a past medical history of PPH following her first pregnancy, and she had received 1 unit of blood transfusion at that time. On admission, the team was alerted for active management of third stage of labor with routine precautions. Next slide, please. The labor was augmented with an ARM, and active pushing of labor was commenced when the cervix was fully dilated at 10 cm. She developed deep transverse arrest, and baby was delivered by venous delivery, and baby weight was 3.75 kg, and the Apgar score was 9/10. Immediately after delivery of placenta, she complained of intense lower abdominal pain with signs of hemodynamic shock out of proportion with blood loss. My question to Dr. Dipankar Mandal: what is the provisional diagnosis and how to confirm?
Good evening, madam. So that case is 35 years old, and after she had a deep transverse arrest, and after that she developed after delivery she developed intense pain. So probably she in my mind, so that will be a case of inversion, uterine inversion. Otherwise, intense pain will not be there so much. So probably
Yes.
This is a case of uterine inversion. So in that cases, I will call for help to the senior obstetrician in that cases which are available in the labor rooms, and in that cases I will try to palpate the do a vaginal
repositioning.
Yes, reposition of the reposition of the inversion portion to the fundus. In that cases, I will try to correction it through vaginally first, and I will fish the and give a push to the fundus, which is coming out from the normal position towards the uterine cavity or towards the vagina, and my left hand will be in the abdominally, and try to try to feel the dimple of the fundus. In that cases,
Dr. Dipankar, my question is how to confirm it that it is a case of uterine inversion. What are the
if
clinical?
I can feel that the large boggy mass is appearing to the introitus,
Yes,
that
yes.
is up to the last stage. And if in the previous stage, if I can feel something within the uterine cavity also or within the vagina, a boggy mass is felt, then and placenta is attached on the top. And the placenta is, uterus is also atonic in that cases, not hyper contracted so much. And the patient is having severe pain in the lower abdomen. In that cases, I can diagnose the case of uterine inversion.
Yes.
And along with that, shock will be there. Disproportionate shock.
Rightly said. Now I'm moving to next slide, please. My next question is to Dr. Ateen Haldar. What are the precipitating factors for uterine inversion?
Actually, I think the incidence of inversion is definitely reduced. In last 10 years, I have not seen a case of inversion in my institution. And when I was in North Bengal, I have seen so many cases. They are from the tea garden area. Actually, I work in North Bengal Medical College, and the patient came from that area because they are the dyes. Most of the time the patient delivered in the home, and the home delivery done by the dyes, untrained personals, and they give the traction over the placenta. And if placenta there is adhesion, that leads to inversion. So placenta accreta that is one of the cause, and early removal of placenta before properly contracting the placenta, there is chance of placenta inversion. This is the main cause. That one is early traction, another is accreta. So, and other factors, that is there are previous surgery is there. So these are the factors which may cause placenta inversion.
Yes, and a rare cause is connective tissue disorders such as Marfan syndrome and all, where the weakening of uterus is there, which may precipitate inversion.
Very rare. Okay.
Yeah,
yes.
yeah, it's very rare cause, just for academic purpose.
So one thing I want to add here, I have presented a case report that a patient came to me with only 16 weeks pregnancy and given misoprostol, and their placenta accreta, and that patient developed placental inversion after extraction of the fetus. That was an interesting case, and ultimately I have to manage it in the hospital. So that's why in every cases, before doing misoprostol, even if it is 16 weeks or 20 weeks during termination of pregnancy, one should go for definitely ultrasonography to know the placental situation. So that is also important point.
Thank you. That was a very important. Yes, Priyanku, just before.
No, ma'am. I was just saying what you just started saying, ma'am. It's a very important point that Dr. Ateen has just mentioned, because even if it's a termination, if it's a case of a previous cesarean section and the placenta is anterior, we definitely have to keep it in mind that it could be a case of a placenta accreta spectrum. Even in cases, ma'am, I think in today's day, in this medical legal field especially, even for people who are like, since Sir was mentioning about termination of pregnancy, even for patients who are 6 weeks, 8 weeks, in case if we are going for termination of pregnancy, I think it's a must for us to get an ultrasound done to look at the localization of the fetal pole, because it could be ectopic pregnancy otherwise also. But since we are talking of placenta accreta spectrum, 12 weeks, 14 weeks, whatever it is warranted, without getting an ultrasound done, we should definitely not attempt termination of pregnancy. Plus, in case if we are seeing it's an anterior, because today, I think talking of MRI for diagnosing placenta accreta spectrum is something that is becoming of the yesteryears, because we do not need it routinely. A good ultrasound is good enough for us to diagnose placenta accreta spectrum with the blood vessels that are traversing through the myometrial wall, the thickness of the myometrial wall, plus the bladder myometrium interface, etc., tells us a good picture of it. And by that, I think we have to have a diagnosis, and also importantly, take a good consent, because a good consent will only save us ultimately in case if we land up with hysterectomy or any problem also.
Yes.
Thank you, Priyanka. One point a wonderful like input by Dr. Arti and Dr. Priyankur, that though what we say, yes, we don't see inversion that often what we are seeing in the young days, but again, the WHO has put the bar in the active management of third stage of labor that controlled contraction only when some person is experienced it. So so the wrongly done contraction can cause milder degree of inversion, and not this sort of inversion, but the milder degree of inversion can really die. You are not sure that it is a postpartum hemorrhage, what is the cause. So like emergency ultrasound to see the uterus location, because milder degree of uterine inversion still we encountered that the people like have this thing, and the management of PPH is different, like the deposition. So the wonderful input by everyone. So yes.
Yes, moving to the next part, may I ask Dr. Smita Das how to manage a case of uterine inversion?
So like we all know, this is an emergency, and so we first start by shouting for help, call for help, and then we resuscitate the patient like any other case, A, B, C, V, C, and then we specifically ask for an anesthetist colleague, because we cannot, ideally we should try the repositioning only under general anesthesia. In case we do not have someone, we can use IV diazepam, and then we try to take the patient, shift the patient to OT, and we have ensured that we have blood in hand, we have the basic ABC has been taken care of, and then we try to reposition it manually.
Yes, because of its emergent nature, I think we should try to manually repositioning the
Another very important thing before trying the repositioning is, we have to stop any. Yeah, we have to stop if any uterotonics that we have started. If the syntocinon drip is on, we have to take care that it has been stopped.
Yeah, and if the manual replacement fails in operation theater, then hydrostatic replacement should not be delayed. And surgical replacement is the last resort, and it is done only if all the maneuvers fails. And next slide, please. Yeah, in surgical method, there are two procedures: Huntington's procedure and Halton's procedure. May I request our expert panelist, Dr. Priyanka Roy, to please explain the procedures?
Yes, ma'am. So basically, as has been said, ma'am, so once if the inversion has happened, as has been said, initially, if we can reposit vaginally, that's the best thing that we can do, the O'Sullivan's technique that we talk of. If that is not possible, then we can go for these two H that we used to remember in our PG days, Huntington's and the Halton's method. So basically, ma'am, both the methods are when we do a laparotomy, first of all, and depending on whether the ring is more anteriorly or posteriorly, we take up the procedure. So with one of the procedures, we will be basically like in the Halton's procedure, as you can see, the incision is made in the posterior surface of the uterus. So basically what happens, ma'am, I'll not read out the slide, but I'll just say that what we normally do is if the uterus is outside, then what is routinely done is what one person from the vaginal end usually takes a sponge holder and puts a gauze piece to that and tries to push up the uterus from the below. And from top, we try to take Alice and we try to pull it up from the top. So once we are doing that, we have this constriction ring in between, which will not allow that reposition of the uterus to happen. So the constriction ring can be dissected out. So in the Huntington's procedure, it is usually the anterior when the constriction ring is there and we make an incision. In the Halton's procedure, it is usually when it's posterior and we make the incision and we pull up the uterine fundus up. And in case if the constriction ring was small and we have made a small incision, we can just suture that up and that leave the uterus in position. But in some cases when it's not possible and uterus is almost come in a piecemeal sort of a thing, they might land up in hysterectomy as well. But in case we are doing a Halton's and we have done a conservative management, we have resutured the uterine cavity, then it is also sometimes possible that we have to remember the chance of relapse of the inversion can happen. So we need to keep in mind that till the uterus has come to a nicely constricted position, we have to give uterotonics as well as, if possible, maybe put in a Foley's catheter or a sense-taken valve inside so that the uterus doesn't go in for a relapse of the inversion.
Just 1 minute.
Sir?
Yes. Just one thing. I have done 5 cases in placental inversion with Halton procedure. The advantage of Halton is that you see actually bladder remains anterior to the uterus. So if that's why Holton, the posterior incision is very easy and we will not disturb bladder. Number one. Number two, I don't know how many doctors are having this experience. It's very difficult procedure, not so easy, because whenever we are pulling the uterus and after 1, 2, 3, 4 hours, the time goes and there is a severe edema occurs in the lip of the uterus. So it is very difficult to pull out easily. That's why there is very chance of tearing of the uterus. And that's why that procedure is very, very delicate procedure to preserve the uterus. And third thing is that what I have done, that what we have, that there is reversion of the uterus, that to avoid this procedure, I have done compression suture after doing Holton. That is also my just little changes of this operation, not only just leaving the uterus. And I follow up this all 5 cases, and one of these cases was came to me with adhesion, that is Asherman syndrome. And again, I have done that synecholysis, and the patient, even after doing Holton, patient delivered in the second times. That's all.
You, Atin, actually, I really agree, and it is a wonderful to have your personal experience. I also think that when there is a irreducible inversion, it is very difficult to reposit from above. And it is something miracle. You cut the incision, the posterior ring, and suddenly everything is fine. Uterus is deposited, and you can repair the uterus like any cesarean section. So it is a very, very instant and very satisfying thing. Suddenly everything is there. So thank you very much for your practical experience. And in my experience also, cutting the posterior ring, especially in chronic inversion, in a irreducible inversion, it really works very well. So have confidence in that procedure actually, and of course all preventive measures for reducing inversion. So thank you very much, Atin, for it.
Thank you, sir, and Sadhna ma'am, for sharing your practical experience. Now I request Dr. Maushmi for the next case.
Yeah. So moving to the third case, Gravida 3 para 2 previous cesarean section. This case was referred by a private practitioner with ultrasound report of referred to a tertiary care center by a private practitioner with ultrasound report showing anterior placenta previa of 36 weeks 2 days. The hemoglobin was 7 g/%. She was a known case of beta thalassemia minor, known case of gestational diabetes mellitus on tablet metformin. Now the ultrasound done at the higher center showed a cephalic fetus of 2.7 kg estimated fetal weight, A5 11 centimeter, placental tissue across the myometrium, retroplacental myometrial thickness is less than 1 mm, and color flow Doppler showed turbulent lacunar blood flow. This is the picture. So what is the diagnosis and how do we plan for cesarean section? Dr. Sindhu Bala?
Yes, ma'am. Recently, last Sunday only, I had this kind of patient. And it was like we two obstetricians has really tough time in the OT. Despite we arranged blood, despite everything, she had intra-op shock. We will arrange blood. We will take the consent for peripartum hysterectomy because removal of placenta can be very, very dangerous for such patient. And she may have, bladder invasion also. So we have to inform a surgeon or a urosurgeon before surgery. That Sunday, we did not get anybody and we had to repair bladder ourselves. And such patient will be taken in OT around 37 weeks. Prior to that, we will transfuse 2 or 3 units of blood to make it at least 10 grams per deciliter.
So diagnosis is placenta accreta spectrum. Yeah.
Yes.
So and the cesarean section has to be done in a planned way.
In a planned way. And prior to that, I'll transfuse blood. I'll make her adequate by hemoglobin wise. She has to be adequate. Consent has to be taken for peripartum hysterectomy. Anesthetist has to be informed. ICU has to be arranged. Blood and blood products should be in hand. And with all the precautions, we will proceed with 2 obstetricians side by side.
Yeah.
And we will also inform one neurosurgeon or a general surgeon because bladder may get, because she has previous to cesarean, bladder may be adherent and it may get. And since it is placenta previa, we have to take out whole of the uterus. Subtotal hysterectomy is not going to help us. And such patient, I recently had such patient last Sunday only, and it took around 2 hours to complete the surgery because uterus is big and I think what mistake we did, give little bit low-lying incision. So we cut a bit of placenta and she bleed from that. So it's to avoid the placenta during the cesarean. Cut above the placenta. Leave the placenta in situ. Do not touch it. Do not try to remove it. Just ligate the cord, hand over the baby, and proceed for hysterectomy straight away. It's futile to fiddle with placenta and attempt and do anything else. And then we can save the patient from massive blood loss and intrapartum hemorrhage and intrapartum shock. And we can save lots of our heart rate and nervousness during that time.
Yeah, very rightly said. So ultrasound with color Doppler.
If I could add, because Dr. Maushami was talking, how do we diagnose? So it has been proven that, TVS ultrasound is indicated in such a patient between 35 to 36 weeks. Before we plan the cesarean, we should ideally have a TVS so that we can have better understanding of the placentation.
Yeah, so ultrasound with color Doppler is actually enough for the diagnosis.
Yeah,
the role of MRI is disputed.
Yeah.
But however, MRI can be done when there is a diagnostic dilemma or in cases of posterior placenta previa. So
another thing is that, hello?
Yes, please.
Yes, another thing is that in that cases, the patient has to be put under general anesthesia rather than spinal anesthesia. And good senior anesthetist should be available in the OT if they are ready to keep the patient under regional anesthesia. Because in that cases, usually patient has to be given vertical incision, midline vertical incision, so that you can, if required, you can put the incision to the upper segment. To avoid the incision through the placenta, you have to, the surgeon may require we can deliver the baby by giving the incision to the upper segment of the uterus, a vertical incision, and just take out the baby, keep the placenta in situ, and go for straightforward hysterectomy.
Yes.
It will be easy.
Yes. And optimizing the timing of cesarean section, this is again a challenge. We have to balance.
Again a challenge,
yes. We have to see the best balance between fetal maturity and the risk of unscheduled delivery. Like if she goes into premature labor in the middle of the night and then whole havoc happens in the night. So again, we have to balance and put a clear line, like wherever it is the best done. And the care should be done in a multidisciplinary team in a center with expertise in diagnosing and managing such cases, as rightly said, with senior obstetrician. Preoperative anesthesia clearance should be done. Neonatologist is very important.
Very important.
Because we are doing hysterectomy in such cases. So the baby should survive. The baby should get the best of care. Blood bank should be alerted. Blood arranged. Urologist should be there. And critical care team is also equally important because post-operative management for these cases is very important.
Ma'am, if I can just add on one thing.
Yes.
Ma'am. Sir, please go on, sir.
Who is speaking? Dr. Rai?
I just want to add one thing. Just you have to counsel the patient and counsel the patient party.
Yes.
In this case, and take the consent before going for an operation. Consent for the hysterectomy particularly. It causes a massive hemorrhage and there may be chance of also the death also. Death consent also is to be taken in this case. And the counseling part is very much important in this case when we go for a laparotomy or cesarean section.
Yeah. Yes, likely said.
Ma'am, if I can just add on one point, ma'am. I think in the OT, when we're taking up this patient, or just before taking up this patient, it is important probably for us to also do an ultrasound, a transabdominal ultrasound, to look at the location, the extent of the placenta.
Placental location.
Because in case we know the exact extent of where the placenta is, we can put the incision just above that so that we do not land up in cutting the placenta, and that helps in reducing the blood loss. I think that is something else that we can add on.
Madam, I want to add one thing.
Yes, please come with your inputs.
Yes, actually, in all cases of cesarean sex, post-CS pregnancy, I think if there is anterior placenta, one must be very cautious. There is every possibility of placenta accreta because the placenta, though it is anterior above, sometimes written by the sonologist, but I have seen some cases where placenta is little bit lower down and there is chance of placenta accreta. So I think it must be a little bit cautious whenever any case of post-cesarean pregnancy with a USG report that placenta anterior, every surgeon should be very cautious.
What Dr. Atin says, actually, it is the same interpretation with the what Kerala Federation, Dr. Pally did in the confidential inquiry of maternal death, that any patient with placenta previa, maybe ultrasound says it is not suggestive of accreta, even sometimes MRI does not actually add much to our management, but readiness to take it as a placenta accreta. So, what is the first, second, third step that on OT you will see just that always the incision above the placenta, you see that the placenta is being separated or not. If you are a little bit full, it is a dimpling sign. So we have to be ready. What Dr. Atin's golden message that every case of placenta previa has to be not taken for the hysterectomy, but we should must keep in mind that if it is needed, that we are ready with the backup like blood and everything. And a second very important thing is that even without cesarean section, placenta previa is a risk factor for placenta accreta. So many patients are taking medical abortion. They have unknown dilatation and curata, sometimes hysteroscopy surgery. So despite having no history of cesarean section, the placenta previa is independent factor for the placenta percreta syndrome. So it is not so that it is always there, but readiness on our part is very, very important. So very nice input by everyone.
Yeah. So moving on with this case, so steroid cover, as we are delivering these patients between 35 to 36 weeks, steroid cover is must. Correction of anemia, as this patient had hemoglobin of 7 gram%. Correction of anemia preoperatively. Blood and blood products should be available. Preoperative counseling and consent about massive obstetric hemorrhage, blood transfusion, increased risk of lower tract damage, and hysterectomy. And so further, the role of hysterectomy, the planned hysterectomy is done in such cases, and the after effects of hysterectomy, that after hysterectomy there will be no menstruation, no childbirth. All this has to be explained in clear words in an understandable language. And local availability of a critical care bed is very important post-operatively to manage such cases. Anesthesia again is either general anesthesia or it can be combined with epidural anesthesia. Cesarean hysterectomy with placenta left in situ after delivery. The choice of incision, again, some people prefer a vertical incision, few also prefer a transverse incision. But
not likely.
But all these patients need total hysterectomy, because subtotal hysterectomy will always leave chances of bleeding. So these patients, however difficult it is, we have to dissect the bladder, push it down, and have a total hysterectomy. Close monitoring of volume status, urine output, and ongoing blood loss and overall hemodynamics is critically important. Critical care services should be available post-operatively, and the ratio of packed RBC, that is blood, FFP, and platelets should be given in the ratio of 1:1:1. Now, this patient, we are lucky in this case because antenatal diagnosis was done. So women with previous previous cesarean section and anterior low-lying placenta at the routine fetal anomaly scan should be specifically screened at 32 to 34 weeks. It can be diagnosed by simple ultrasound with color Doppler. And among women with placenta previa, the risk of placenta accreta is after first, second, third, fourth, and fifth cesarean section rises to the extent of 3%, to 11%, to 40%, to 61%, and as high as 67% after 5 cesarean sections. So these placenta accreta spectrum is now rising, as Dr. Sindhuwala said. So I think every month or every 15 days we are encountering such patients. So we now move on to the fourth case. I request Dr. Sarita to please take on the fourth case.
Thank you, Dr. Mosmi. Moving to the fourth case, I am presenting the history. A 28-year-old third gravida, para 2 living 2, previous normal vaginal delivery, admitted in labor room at 38 weeks of gestation, is in active labor. The course of her current pregnancy was unremarkable. Her labor progressed normally, and the patient spontaneously delivered a 3.6 kg male baby, and there were no vaginal or perineal tears. The first and second stage of labor lasted approximately 4 hours and 30 minutes respectively. The placenta was delivered completely with minimal blood loss. and the patient was transferred to the maternity unit 2 hours after delivery with a normally contracted uterus and without any evidence of abnormal blood loss. Next slide. 4 hours following delivery, patient complained of severe perineal and abdominal pain along with unable to void urine. On examination, patient looked pale, pulse was 100 beats per minute, her BP was 100/60. On abdominal examination, uterus was well contracted and felt at the level of umbilicus, but the right lower quadrant was extremely tender on palpation. On pelvic examination, no obvious vaginal or vulval swelling noted. On rectal examination, no obvious boggy mass felt. Patient's vital further deteriorated and there was a fall of hemoglobin to 7.5 gram% from admission hemoglobin of 12 gram%. Urgent transabdominal ultrasound was done, which showed a hypoechoic mass of 9 into 4 centimeter on the right side with a well contracted uterus deviated to the left. May I ask Dr. Sindhu Bala, what is the diagnosis and what are the causative factors? Ma'am, you are muted. I think you are muted.
Oh, I'm so sorry. I think this is pelvic hematoma, which has extended from the right pelvic wall. Since this baby she was third gravida and the baby was quite big, 3.6 kg. And now we have to see the vitals, continued blood loss, whether she is deteriorating or not. I do not know whether conservative treatment alone could be sufficient for such patient or not, because she has lost significant amount of hemoglobin up to 5 gram during just 2 hours. So she needs to be resuscitated. There is no doubt about it. She needs to be given whatever crystalloid, colloid, blood. Consent has to be taken for re-exploration, and OT has to be informed. Anesthetist has to be informed. And if I think it's better to open up and see rather than give her more time to see whether hematoma is increasing, whether she is deteriorating. It is better to see and look and do the needed repair or clamping or hematoma drainage or internal ligation.
Yeah. Coming to the causative factors, the rapid labor, cesarean section, instrumental deliveries, and trauma are the predisposing factors in the formation of these type of pelvic broad ligament hematoma. And usually these hematomas are the result of upper vaginal, cervical, or uterine laceration extending into the uterine or vaginal artery. Now, please, next slide. Now, may I ask Dr. Deepankar Mandal how to manage the case of broad ligament hematoma?
Broad ligament hematoma, this is a classical case of broad ligament hematoma with right-sided huge hematoma that shift the uterus towards the left. In routine cesarean sections, we are a little bit of facing a broad ligament hematoma, and that is managed in the same sitting. But here the patient is presented with a vaginal delivery,
yes,
and that was precipitated labor. After that, probably the descending cervical artery or something else, probably some cervix has been lacerated or tear during the precipitated labor, and that extends towards the upper segment, that means towards the uterine, proper uterine artery, and that ultimately leads to huge broad ligament hematoma. And so the surgical intervention has to be done. There is no alternative. We have to do it very, call for help to everybody, to the nurses available in the ward, in the OT, and the patient party, and another colleagues of there. If there is my gynecologist colleague, somebody is there, then I have to engage somebody to talk with the patients and patient's relative, and concurrently shift the patient to the OT for management of the patients. In the same sitting, we take high risk consent, and hysterectomy consent should be taken, but final decision should be taken after doing laparotomy.
Yes. Treatments depend upon the clinical circumstances of the patient. In case of a small hematoma not increasing, hematoma should be drained and bleeders should be ligated. ligation of bilateral uterine artery, bilateral ovarian artery, and internal iliac artery ligation or uterine artery embolization is always a possibility. But if this ligation is not possible due to huge hematoma and technical difficulty, then hysterectomy is the last resort. Please next slide. In this case, hematoma was not expanding, hence we left it undisturbed, and intraperitoneal drain was placed in situ. Patient received 3 units of packed cell and was managed in high dependency unit. Catheter was removed after two days, and patient resumed her normal bowel habits, and stage was removed on day day 10. In this case, we have done. We tried internal iliac artery ligation, but because of the huge hematoma and technical difficulty, we were not able to perform this, and this patient
that is very correct. That is very correct, madam. Because in that cases we have to refrain ourselves to not to do internal iliac tie, because in that cases we might endanger the uretary damage also in that cases.
Yes. Because of that fear, because of that fear, we proceeded for hysterectomy.
Yes.
So can I add something here?
Yes, sir.
Yes, sir.
Actually, my experience is a little bit different. In the midnight, I called for a case, a huge broad ligament hematoma. Already my juniors are open, the laparotomy started, and there is a big hematoma on the left side of the uterus. And immediately I enter into the OT. And when that hematoma was so big that nothing could be visible, whether there is a bleeding side and everything. So what I have done, immediately I do first open the broad ligament above and do internal iliac tie first. Then I started to open, and what happens? There is huge bleeding. The hematoma, actually what happened after broad ligament hematoma, the anatomy is totally distorted. Very difficult.
Yes, that is true. That is very correct.
That's why what I have, my experience is immediately I always say that if you could not find anything, you first do internal iliac tie, then open the abdomen. Hematoma side.
Sir, in that cases, you have to do internal iliac tie of the opposite side first.
No.
Then you come to the danger side.
The danger side or opposite side, whatever it may be, you do internal iliac artery first until if you open the hematoma, there will be huge bleeding from different side. You cannot manage
from
the
different side. Yes.
Table.
I agree with Atin sir. Even this is what even we do. If the hematoma is so big, we don't open the broad ligament. We first do the internal iliac and then touch it.
And another thing is that what my experience, I have done another cases where immediately after doing internal iliac tie, again bleeding, I put a catheter, multiple clamp, different side, and I have done external iliac tie also. Intentionally I do it, and patient is on the OT. Then I take the patient to the recovery room and see the pulse with the pulse oximeter, the peripheral pulse, the oxygen saturation, everything. Oxygen saturation drop down. I wait for 2 hours. Then only 30 to 40% oxygen saturation. Then what I do, immediately I call the sonologist. Take the patient. Ultrasonography, portable ultrasonography done in the labor room, recovery room, and I saw that already there is only 50% blood circulated through the femoral artery, because there is already started the collateral circulation, and that patient revived, and ultimately in the next day that is 35%, then gradually improves even after doing external iliac tie. That, and again I called Dr. Sudeep Shah, Professor Medical College, and contact with him. He has done one cases. He told me if there is any pain and gangrene, then you have to ask the vascular surgeon to reconstruct the external iliac. So ultimately we revived the patient, and patient revived better. And in the follow-up, what happens? Patient said that there is pain little bit. Now the patient is coming again to my chamber also after 2 years, when she sees a labor class. So when she is working in the field, she told that she pains claudication pain in the thigh and back calf muscle. Otherwise patient is okay. So if you do external iliac tie, if it is needed, you can go for external iliac. I think that can be done to save the life of the patient. This is my experience in this particular, the rare incidents.
Thank you, Atin. It is something what we are really having a great learning and sharing. And I really congratulate and appreciate like what a wonderful experience, and especially catering in small cities and what you say, the labor class, and how the life is so very important. So rightly said, broad ligament hematoma, always a dicey situation. Sometimes it is press, pack and pray, and it get resolved. It is less lax, and you see it is not increasing. Internal iliac artery ligation and selective devascularization is very, very important. Actually, it is very important step, because from arterial to venous, and if it is not extending, and one patient of mine with the broad ligament hematoma with quite a good hemodynamic instability, but one patient actually in postnatal period, that after resuscitation and tranexamic acid, fortunately that was not extended and the patient recovered well. So broad ligament hematoma, we cannot say it is only a one-line management. Sometimes it is pass, prac and pray. Sometimes it is selective devascularization. Sometimes it is hysterectomy also. But what Dr. Atin and everybody was emphasizing, that we must have a close watch on the patient status. And this is something we always say, internal iliac, so never damage, external iliac, never damage. And Atin's experience actually is think that it was damaged, but patient was well, and we have the vascular surgeon, because life is so very important. I'm really awed with the wonderful experiences of everyone, and we learned a lot in during this discussion, that what is actually happening in our country, and how our obstetrician and gynecologists with their courage and with their skill are saving life. It was something a great day to learn. So
Yes, great, sir. Thank you, ma'am. And I would like to thank all the esteemed panelists for their great input. And now I would like to request Dr. Maushmi for closing remarks.
Yeah, so winding up, PPH can happen without any warning. So we have to stay prepared with all interventions, and these charts of medical management, compression sutures, breathe-in sutures, so these should be displayed in labor room and operation theater, so that the junior doctors, or wherever there is a dilemma, where there is doubt, we can refer to these charts. And these PPH tests or these drills should be done periodically in labor room, so that the cohesiveness of the team is actually there, and whatever lacuna is there can be rectified before such incident happens. So moving together, having regular drills in the labor room, and having proper protocols displayed is the key. So I thank my co-moderator, Dr. Sarita, and all the lovely panelists for such wonderful interaction.
Thank you so much, ma'am. And absolutely, it was wonderful interaction. And I would definitely want to wish Sadhna ma'am all the very best for her election campaign. And ma'am, I wish we continue with such academic endeavors, because it really helps in learning and really helps in teaching, and especially building up that, the sort of a revision of what we have learned previously. So all the best to you, ma'am.
Thank you, Priyanka. Thanks a lot.
Over to Dr. Ayush
for having us. It was really an honor and privilege, and I think it was so interactive, and it was very, very helpful and learning experience. And of course, all the very best, ma'am. It's a great initiative that you have started, and we really look forward to many more such events.
Thank you, Smita, and thank you everyone, Sabyasachi, Atin, Sindhubala, Priyankur, for your precious time. I think you are busy, but you took your time. So a special thanks to Priyankur and Dr. Detu. It was something very wonderful, like what we are saying, and we have a lot of innovation, like Naldi, the plastic drape. It's simple innovation, and how our courage, because sometimes we talk very much, yes, legality is there, media issue is there, patient resistance is sometime on the way, but finally actually it is our courage and our close communication heart to heart. So every situation, though it is today that we are sometimes negative perception with the patient, but still I say to every young person, senior person will be of same opinion, that if we are very earnest in communication and communicating the things what we are happening, most of the people will appreciate it and they will cooperate. So that apathy and the transparency and honesty has to be there in difficult situations, so that they don't take time, don't do hysterectomy, don't do hysterectomy. So they are with us. So thank you very much. It was really very, very good to listen to all panelists. It was something, and I
Thank
hope
you, ma'am.
Thank you.
Thank you for making us participate in such a wonderful
And all the
seminar.
best, ma'am.
Thank you, thank you, thank you.
Okay. Thank you, madam.
May I
Thank
request
you all.
Ayushi, Dr. Ayushi?
Thank you, our respected moderators and the panelists, for this enlightening session. My sincere thanks and gratitude to the societies of Asansol, Bardhaman, Malda, Siliguri, and West Mednipur. I would like to thank Dr. Professor Geeta Ganguly ma'am for sending her best wishes for the program. My sincere thanks to Dr. Ram Prasad Desa for his gracious presence and the words of wisdom. My gratitude to the presidents, secretaries, and the seniors of the societies, Dr. Sushanta Kumar Das sir, Dr. Anup Kumar Malik sir, Dr. Shankar Des sir, Dr. N.R. Saha sir, Dr. Amitwa sir, Dr. M.P. Malik sir, and Dr. Ratan Kumar Das sir for chairing the session and for their valuable inputs. Regards and thanks to our wonderful speakers, Dr. Sadhana Gupta ma'am, the key organizer of this series of program, for the excellent talk, Dr. Nalini Mishra ma'am, for sharing her innovations and the videos which are full of practical tips. Dr. Shashilata Kabra ma'am, although ma'am could not be there with us physically, but we all know her videos are full of knowledge and very informative. I would like to extend my heartfelt gratitude to our moderators, Dr. Moshmi Das Ghosh ma'am and Dr. Sarita Kumari ma'am, for planning such brainstorming cases, and our esteemed panelists, Dr. Sutappam Samanta sir, Dr. Smita Das ma'am, Dr. Sabyasachi Ray sir, Dr. Amit Datta sir, Dr. Atin Halder sir, Dr. Sindhu Bala sir, and Dr. Sindhu Bala ma'am for their valuable insights and engaging discussion. Thank you, Dr. Priyanka Roy sir, for sharing your expertise. That is truly appreciated. Once again, thank you, Dr. Moshmi Das ma'am, for all your hard work for this program. Thank you to the IT team for the coordination and the smooth running of the program, and our audience for the patience listening. And definitely we all have benefited from today's program. Thank you.
Thank you, Aishi. Thank you. Thank you, Moshmi. So with again, gratitude to Dr. Vishwajit, Dr. Shankar, Dr. Sushanta, Amitwa, Dr. Everyone, Dr. Rudren, Dr. Ratan, Dr. Gushta, Dr. Udayan, Dr. Anup, and Dr. Malik for making this happen and coming, like we have organized in a very small span. And we look forward to many such programs, and some way always like to visit in person to beautiful places. Few I have been, like Shanti Niketan, that Kalyani. So it is so good to be a Bardhaman. I still remember the melodious evening when Ashish organized Eastern Yuva Foxy, and Priyankur is one of the rising star in Foxy, and he is so hardworking and dedicated. So actually, this is the way ahead that this is, as a presidential candidate, this is one of very, very important concern that we need to include every expertise and experience from every place of the country, and only then we can serve our people. We can be strong as a professional body, because that is the need of the day. And the experience like Sabyasachi, Dr. Atin, it is so very important that we carry forward, and we have to create the confidence in our OB-GYN Ved Seva. So this is why one thing, that excellence is at every level. It is not related to any place or any zone. It has to be like uniform. So once again, gratitude for all your precious wishes. I again, as a presidential candidate, I request that please nominate my name as a Foxy presidential candidature, vote and support, and we look forward for a combined shared vision for women health as well as the fellow OB-GYN. So thank you once again.
Thank you, madam, for the opportunity.
Thank you, madam, and our best wishes to madam.
Thank you, sir.
For
Thank
the
you.
upcoming election as a presidential candidate, Foxy election.
Thank you, Dr. Zeta. Thank you, Dr. Day. Thank you.
Yes, thank you. Yes.
So Chitrakala, with the permission of Dr. Day is with us. Thank you, Dr. Day, for being till nine. You can say good evening and a good night.
Good night. Good night, everybody.
Good night.
Good night.
Good night.
Thank you all. Good night.
Thank you, ma'am. Thank you, ma'am.
Thank you. So Chitrakala, you can
Thank
add
you and
something.
good night all.
Thank you.
Sure, ma'am. Sure.